The entire emergency room stopped when she walked in. Not because she was loud, not because she demanded attention, because one of the most decorated trauma surgeons in the Pacific Northwest took one look at the new nurse adjusting her badge at the intake desk and said, loud enough for everyone to hear, "Someone tell administration we need staff, not volunteers." The laughter that followed was immediate, comfortable, the kind that comes easy when everyone agrees on who doesn't belong. She didn't flinch. She didn't look up. She just set down her bag, checked her watch, and waited. Nobody in that room knew they were standing next to the most dangerous person in the building. Before we go any further, if you're new here, hit that subscribe button right now because this channel is where the stories that keep you up at night live. Give this video a like if you're already hooked, and drop a comment telling me what city and country you're watching from. I want to see how far this story has traveled. Now, let's get into it. The morning shift at Crestwood Regional Medical Center started the way it always did in mid-October. Gray sky pressing down on the Columbia River Gorge outside Harlow, Oregon, the kind of cold that got into the joints before 7 a.m. and stayed there. The parking lot filled in waves, coffee cups, badge swipes, the particular quiet of people moving through routine so deeply worn that nothing registered anymore unless something went wrong. Something was about to go wrong. Her name was Nora Vance. She was 32 years old, 5'6", and she carried a single duffel bag through the hospital's main entrance like she was checking into a roadside motel. No conversation, no visible nervousness, the kind of stillness that people sometimes mistook for vacancy. She had dark circles under her eyes that suggested either bad sleep or a very long drive, and her scrubs were clean but not new, the kind of worn-in fabric that comes from 1,000 laundry cycles and actual use. Her paperwork had been processed by HR 3 days earlier. She was officially a floor nurse assigned to the emergency department, level 2, non-supervisory, starting today. The charge nurse at the intake desk, a compact woman in her late 40s named Sandra Okafor, looked up when Nora approached. "You Vance?" "Yes." Sandra scanned her up and down the way people do when they're making a decision they've already made. "All right, locker room's down that hall, left at the supply bay. You'll be on observation first. We don't put new transfers on active cases right away." "Understood." "You come from—" Sandra glanced at the file. "Bayfield Community. That's, what, 100-bed facility?" 98. "Right." Sandra handed her a badge lanyard. "This is a 412-bed level 2 trauma center. It's different." "I'll learn fast." Sandra almost said something else, but her radio crackled and she turned away. Nora took the lanyard, found her own way to the locker room, and spent 4 minutes getting oriented. She did not appear to need more than 4 minutes. The emergency department at Crestwood Regional was built in the shape of a rough U, intake and triage along the base, trauma bays on the right arm, general emergency on the left, with the nurses' station occupying the interior curve. It was a good layout for visibility, the kind of layout that experienced trauma staff came to depend on, because in a real emergency, you needed to be able to see 3 things at once without physically moving. Nora noticed this within 10 minutes of stepping onto the floor. She also noticed which monitors were older and which had calibration drift, which supply cabinet had the key that stuck, and which of the orderlies moved fast when called versus which ones took the long way around. She did not write any of this down. She didn't need to. The first doctor she encountered was not Dr. Elliot Graves. It was a second-year resident named Priya Anand who nearly walked into Nora while rushing toward a supply bay with an armful of IV kits. "Sorry, you're new? ER3 needs a second line placed on a post-op bowel patient who's been bouncing between departments. Bed 12. Nora nodded and followed without asking for clarification. The patient in bed 12 was a 57-year-old man named Gerald Russ, who had the look of someone who had been in the hospital long enough to stop expecting good news. He watched Nora approach without particular interest. "Another one," he said. "Another what?" "Another person who's going to poke around and tell me everything's fine. I'm going to place a second IV line. It might pinch." Everything pinches. She found the vein on the second attempt, not the first, because the first site she assessed had a slight firmness that suggested subclinical infiltration from a previous line. She noted the discoloration and moved 3 centimeters proximal before placing the catheter cleanly. Gerald Russ watched her with slightly more attention than before. "You're quiet," he said. "Yes." "The other nurses talk the whole time. I think they think it helps." "Does it?" He considered this. "Not really." The line was in. She secured it, labeled it with the time and gauge, and was turning to go when she noticed that the existing IV line, the one running a saline drip, had an occlusion indicator starting to climb. It wasn't alarming yet. It would be alarming in approximately 40 minutes when the pressure differential became critical and the pump began compensating by increasing flow rate. She adjusted the line, checked the catheter tip position, and added a note in the chart before walking out. Priya Anand was waiting in the hall. "Fast. Good. You can trail me until Dr. Graves gets in, and then—" "Graves?" "Elliot Graves, chief trauma attending. He runs the ER." Priya paused. "He's very experienced." The pause carried information that the words didn't. Nora filed it. Elliot Graves arrived at 8:14 a.m., which was 11 minutes after his scheduled start, a pattern that Nora would later understand was so consistent it had stopped registering as lateness and had simply become the adjusted baseline. He was 51, broad-shouldered, with silver at his temples, and the deliberate cadence of a man who had learned that speaking slightly slower than necessary made people wait for what he said. He had published 7 papers in trauma surgery. He had been chief attending at Crestwood for 6 years. He had strong opinions about almost everything. He noticed Nora standing near the nurse's station, the same way you notice furniture that's been moved. "Who's this?" Sandra answered from across the desk. "Transfer? Vance. Starting today?" Graves looked at Nora. "Where from?" "Bayfield Community." Han made a sound that wasn't quite dismissive and wasn't quite polite. "Community hospital nursing. All right. Stay on observation today, maybe tomorrow. Don't jump into anything until you know the rhythm here." "Of course." He walked past her toward the trauma bay without another word. What happened next was unremarkable, which was part of the problem. For the first 2 hours of her shift, Nora did exactly what she was told. She observed. She stayed out of the way. She did not interject, did not volunteer opinions, did not do anything that would draw attention. She watched how the team communicated under pressure, which doctors listened to which nurses, where the hesitations were, where the confidence was misplaced. She built a map of the department in her head that was more detailed than anything on the organizational chart. At 10:37 a.m., a 23-year-old male came in by ambulance following a car accident on the interstate. Moderate mechanism, airbag deployment, ambulatory at the scene, now complaining of right-side chest pain and mild shortness of breath. Vitals on arrival: BP 122/78, HR 94, oxygen saturation 97% on room air, GCS 15. The paramedics had done everything correctly. Dr. Graves assessed the patient, a young man named Tate Kellerman who kept asking about his truck, and ordered a chest X-ray, standard labs, and an EKG. Nora was charting at the station when the X-ray results came through. She looked at them for approximately 12 seconds. Then she looked at the patient through the bay window. She looked back at the X-ray. She walked to where Priya Anand was writing notes. "The right costophrenic angle is blunted," Nora said, keeping her voice low. Priya looked up. "The X-ray just came in. Dr. Graves hasn't reviewed. There's also a subtle tracheal shift. It's mild, but it's there. And his SAT has been trending down, 97 at arrival, 96 8 minutes ago, 95 now. It's not alarming individually, but the direction—" "Okay, slow down." Priya lowered her own voice. "You've been here 4 hours. I wouldn't walk up to Dr. Graves with this before I was absolutely sure." "I'm not walking up to Dr. Graves, I'm telling you." Priya looked at her for a long moment. Then she looked at the monitor readout. Then she looked at the X-ray image on the screen. She went to Dr. Graves. Graves reviewed the X-ray with the particular patience of a man being asked to confirm something obvious. He looked at the costophrenic angle. He looked at the trachea. He looked at the trending saturations. Then he looked at Nora, who was standing several feet away, not quite making eye contact. "You flagged this?" "I mentioned it to Dr. Anand." "You've been a nurse how long?" 8 years. "At a community hospital?" "Yes." He was quiet for a moment. "The blunting could be diaphragm position. The trachea is within normal limits. The SAT drop is 2 points over 8 minutes, which is not—" "I know what the differential is," Nora said. "I'm not suggesting immediate intervention. I'm suggesting a repeat X-ray in 20 minutes and a lower threshold for a CT if the trend continues. The room was not exactly watching, but it was not exactly not watching either. There's a particular quality of attention that emerges in an ER when someone has stepped outside their expected role. Graves held her gaze for a moment. Sandra, repeat chest film in 20 minutes on Kellerman. If the SAT drops below 94, get me. He walked away. It was not agreement. It was not acknowledgement. It was the minimum concession that managed the situation without giving ground. 22 minutes later, Tate Kellerman's oxygen saturation dropped to 93%. The repeat film showed a hemothorax that had been accumulating since impact, small, easily missed on the initial imaging, but real and expanding. Dr. Graves placed a chest tube without speaking to anyone unnecessarily. The procedure was clean and effective. Kellerman stabilized within minutes. Nobody said anything to Nora. She went back to her charting. But two nurses who had watched the whole thing exchanged a look that said something neither of them put into words yet. The shift change at 3 p.m. brought the afternoon crew in a brief lull, the kind that ERs get sometimes. Not quiet, exactly, but lower in pitch, like a machine between cycles. Nora ate half a sandwich standing at the medication cart because there was no obvious good time to sit down, and she had stopped expecting one. She had worked 8-hour days where she sat for a combined total of 11 minutes. This did not particularly bother her. Dr. Graves reappeared after a brief administrative break and moved through the department doing the thing that department chiefs do, visible but not engaged, present without being available. He stopped near the nurse's station and found himself standing next to Nora, who was updating a medication log. "Kellerman case," he said, not quite to her. "Yes?" "You got lucky on the read." She didn't look up from the log. "I'm sure you would have caught it." The flatness of the statement made it ambiguous. It could have been sincere, or it could have been something else entirely. Graves looked at her for a moment, then moved on. What he didn't say, and what no one in the department said, was that in the 6 years Graves had been chief attending, no nurse had flagged a developing hemothorax before the second set of vitals dropped. It wasn't the kind of thing people announced, but it was the kind of thing that stayed in a room even after the moment passed. The evening escalated the way the best and worst ERs do. Not in one dramatic surge, but in a series of overlapping complications that compounded each other. By 6 p.m., there were 4 critical patients, a waiting room at capacity, 1 ventilator with a sensor warning that maintenance hadn't cleared yet, and a new trauma activation called in from the highway. The activation came in as a motorcycle versus a semi, which was the language used to describe something that was almost never survivable in the way the words implied. The patient, later identified as 44-year-old Wayne Dressler, arrived with compound fractures of both legs, a suspected pelvic ring disruption, and blood pressure that had already dropped to 84 systolic during transport. Dr. Graves ran the trauma bay. He was very good at this. Whatever Nora had privately assessed about his ego or his habits or his management style, she had no professional criticism of his hands in a trauma bay. He moved with economy, and he talked with precision, and he kept his team organized under pressure. Nora was not assigned to the trauma bay for this activation. She was on the general emergency side, managing 4 patients simultaneously, which required actual skill because one of them, a 68-year-old woman named Dorothy Mays with a history of congestive heart failure, was presenting with what her previous chart noted as a routine exacerbation, but whose respiratory effort had been subtly but progressively worsening since arrival. Nora had adjusted Mrs. Mays's diuretic rate twice. She had repositioned her and reassessed 3 times. She had flagged the chart for physician review at 5:40 p.m. The review hadn't happened because the physician assigned to the general bay, a hospitalist covering for a missing attending, was managing 2 other complicated patients and had added Mrs. Mays to a queue. At 6:23 p.m., Mrs. Mays's respiratory rate hit 28 per minute, and her saturation dropped to 89 on room air. Nora was at her bedside before the monitor alarmed. She increased oxygen delivery, repositioned the patient to high Fowler's, and was hanging a nitroglyceride drip within her protocol scope, when the hospitalist, Dr. Kurt Paulson, appeared in the doorway. "I was about to get to her. She needs BiPAP," Nora said. "Her work of breathing is increasing and the diuresis isn't moving fast enough." If we wait for the nitro to take full effect before considering non-invasive ventilation, the window gets tight. Paulson was not an arrogant man. He was a tired man who had been on shift for 11 hours and who knew, when he looked at Dorothy Mace's respiratory effort, that the nurse was right. "Call respiratory therapy," he said. "I'll get the orders in." Nora was already reaching for the call button. The BiPAP went on within 9 minutes. Mrs. Mace's numbers improved within 20. She was transferred to the cardiac care unit at 7:45 p.m., stable. Dr. Paulson found Nora at the nurse's station afterward. "You've done this before," he said. "Done what?" "Managed a CHF exacerbation going bad before it went obvious." She entered the last notation in the chart. "I've seen a lot of sick people." He watched her for a moment like he was trying to read something that wasn't written on the surface. Then he went back to his next patient. It was 8:50 p.m. when Dr. Graves made his comment. The department was in a middle state. The worst of the evening rush was through, but 2 critical patients were still being managed, and the staff was running on the particular fuel of people who had stopped feeling tired because there was no time for it. Nora was at the medication cart when she overheard Graves speaking to 2 of his senior residents, Marisol Fuente and Dominic Kessler, near the trauma bay entrance. They were doing a debrief on the Dressler case, which was a legitimate and useful clinical conversation. But then Graves said, unprompted, "And for the record, the new transfer flagging the Kellerman case this morning. Don't let that kind of thing set precedent. Community nurses come in thinking pattern recognition is the same as clinical authority. It's not." Fuente nodded carefully. Kessler looked at his shoes. "If she'd been wrong," Graves continued, "we'd have caused unnecessary alarm on a stable patient. The appropriate thing is to report to the physician and let the physician assess, not to circulate concerns through resident channels before anyone's even reviewed the imaging." He didn't raise his voice. He didn't appear to be performing for anyone. He was simply establishing an order of things, the way chiefs did, and nobody in that hallway contradicted him. Nora heard it from 12 feet away. She was close enough that it would have been impossible not to. She continued pulling medication from the cart in the correct order without pausing or speeding up or looking in his direction. She had heard worse. She had been dismissed by people operating in conditions where dismissal had lethal consequences. She had learned a long time ago that the size of the insult didn't determine the appropriate response. Timing did. She finished what she was doing and went back to her patients. But Marisol Fuente, walking past the medication cart 30 seconds later, caught Nora's eyes for just a moment. There was something in the resident's expression that wasn't apology exactly, but was adjacent to it. The look of someone who recognized the moment for what it was and felt its weight. Nora gave a small nod and went back to work. At 9:42 p.m., 3 things happened in rapid succession. First, Sandra Okafor announced a mass casualty notification from County Dispatch, a structural collapse at a construction site in the industrial district, approximately 6 miles away. Estimated 12 to 15 casualties, ranging from minor to critical. ETA on first ambulance, 11 minutes. Second, the department's ventilator with the sensor fault, the one that maintenance had not yet cleared, alarmed on a post-operative patient who had been stable for 4 hours. The sensor fault turned out to be an actual partial obstruction in the expiratory circuit, which required immediate manual management while the equipment team was called. Third, Dr. Graves, who had been in a consultation room reviewing imaging for a non-urgent patient, came out to find his department reorganizing for a mass casualty event with 1 piece of critical equipment down. "What's the vent status?" he called. "Circuit fault, team's coming," Sandra said. "Who's managing manually?" Nora was already at the patient's bedside, standing to the side of the ventilator with one hand on the manual bag valve and her eyes on the patient's chest rise. She was not alarmed. She was simply doing the most important thing that needed doing. Graves looked at her for approximately 2 seconds. Then he turned to the rest of the team. "Get Trauma Bay 1 and 2 prepped. I want blood on standby. 4 units O negative. Ortho on call now. Respiratory to the vent patient. Relieve that nurse to prep." He was already moving. "Anand, walk me through triage as they come in. We move everyone who can move." The next 90 minutes were not cinematic. Mass casualty events almost never are. They are loud and logistically brutal and filled with moments of specific narrow focus, while everything peripheral becomes noise. 12 patients arrived in 4 waves, broken bones, crush injuries, lacerations, one patient with a suspected internal hemorrhage, two with head trauma of varying severity. Nora had been reassigned to triage assist when the equipment team reached the vent patient. She moved through incoming patients with the particular efficiency of someone who has performed triage under conditions considerably worse than a well-lit emergency department with supplies available. She used the assessment criteria correctly and flagged patients in the right priority order and did not second-guess anyone unnecessarily. And when a paramedic misread a BP cuff error and classified a patient's systolic as 110 when it was actually 78, Nora caught it before the patient was moved to a lower priority bay. "Recheck on this one," she said, holding the paramedic's clipboard. The recheck confirmed 76 systolic. The patient went to Trauma Bay 1. Dr. Graves, passing through, registered the correction without comment. By 11:30 p.m., 11 of the 12 patients were stable or upgraded. The 12th, the suspected internal hemorrhage, was in emergency surgery. The department was running on cleanup protocols and the specific exhaustion that comes after sustained high-intensity work. Nora sat down for the first time since 10 p.m. in a chair near the nurse's station. She drank cold coffee from a cup that had been sitting there for 3 hours. She looked at nothing in particular. Sandra Okafor appeared beside her. The charge nurse sat down heavily in the adjacent chair. "You do triage a lot at Bayfield?" Sandra asked. "Sometimes. You move through those patients fast. The prioritization wasn't complicated. Clear criteria." Sandra was quiet for a moment. Graves noticed the BP catch. It was the paramedic's equipment. He noticed anyway. Nora drank her coffee. "You did good today," Sandra said, without fanfare, the way experienced charge nurses say things. Not as encouragement exactly, but as accurate assessment. Nora nodded. "Thank you." "You want the day shift tomorrow or the overnight?" "Whichever you need covered." Sandra looked at her sideways. "Most people have a preference." "I'm flexible." It was the kind of answer that implied something without explaining it, the kind that people either ignored or filed away. Sandra filed it away. It was past midnight when the shift technically ended for Nora, though she stayed to complete 2 charts and assist with the transfer of the cardiac patient who'd come in at 11 p.m. She was at the intake desk retrieving her duffel bag from the cabinet where she'd stored it that morning when she heard Dr. Graves's voice in the break room. Not directed at her, not aware she was there, talking to Dominic Kessler in the low register of people who thought they were alone. "She's competent," Graves said. "I'll give her that." A pause. Then Kessler said something she couldn't hear clearly. "Doesn't matter," Graves said. "Competence is baseline. The issue is integration. Community background means she's used to being the most experienced person in the room. That doesn't translate here. She's going to have to understand her position before she starts thinking she can flag cases around the attending on duty." Another pause. "Keep an eye on it," Graves said. Nora picked up her bag. She walked to the exit without looking at the break room. Outside, the October air was sharper now, the parking lot half empty, the sky that specific quality of dark that happens between midnight and 2 a.m. She stood next to her car for a moment, keys in her hand, not quite ready to sit down. She was not angry. Anger was a luxury she had learned to defer for situations where it actually changed something. What she was, standing in the parking lot of Crestwood Regional Medical Center at 12:23 a.m. on her first day, was precise, calibrated, waiting. She had been told where she was. She had been told what she was expected to be. She had taken the measure of everyone she'd worked beside, from the charge nurse who was fair to the chief attending who was not, and she had not corrected anyone's assumptions about her because correcting assumptions was not the point. The point, as it had always been, was the patient's. She got in her car. She drove to the apartment she was renting by the week 3 miles from the hospital. She set an alarm for 5:45 a.m. She was asleep in 4 minutes. She did not dream about the hospital. She dreamed about a road in a country most people had only seen on a news feed, a road she had driven in the dark with no lights on, and a patient in the back and a radio that kept cutting out, and the particular quality of concentration required when you understood that every decision in the next 9 minutes had exactly 1 margin of error and the margin was 0. When the alarm went off, she was already awake. She got up, made coffee, and looked at the rain coming down on the street outside her window. Then she picked up her bag, checked that everything was where she'd left it, and went back. She always went back. The second day started the way the first one had ended, with someone at Crestwood Regional Medical Center underestimating Nora Vance. This time, it would be the last time anyone did it quietly. The second day started the way the first one had ended, with someone at Crestwood Regional Medical Center underestimating Nora Vance. She came in at 6:02 a.m., 8 minutes before her scheduled start, because she wanted to read the overnight notes before the morning briefing, and because the alternative was sitting in her apartment watching rain streak down a window she hadn't yet decided how to feel about. The overnight charge nurse, a thin man named Felix Oubre, who had been working nights at Crestwood for 11 years, handed her the summary sheet with the particular blank efficiency of someone mid-transition between worlds. "Quiet night after your MCI," he said. "4 admits, 2 discharges, 1 surgery consult still pending. Bed 7 is a GI bleed. Stable, but watch the pressure. Bed 11 is a pediatric fever. Parents are anxious. Kid is probably fine." Probably? Temp came down with Tylenol, but mom's a nurse herself, which makes it complicated. Nora scanned the sheet. "Who's the attending today?" "Graves is off. You've got Dr. Lindquist covering until noon, then Graves comes in for evening." She looked up. "Lindquist." "Renata Lindquist. She's good." Felix said it the way people said things when they were distinguishing someone from a difficult comparison. "Actually listens." Nora nodded, handed back the summary, and went to check on bed 7. The GI bleed patient was a 61-year-old named Harrison Polk, and he was awake, which was either a good sign or the kind of sign that meant he'd been awake for 3 hours worrying. He had the yellow-gray quality of someone who had lost more blood than he'd admitted to initially, and who had been eating ibuprofen for a knee problem without telling his GP for 4 months. "How are you feeling?" Nora asked, checking his IV access. "Like I swallowed something that's disagreeing with me." "You did, technically. How's the pain?" 6, maybe 7 if I move." She checked his pressure, 108 systolic, down 4 points from the 3 a.m. notation. Not alarming, but directional. She checked his hematocrit from the last draw, looked at the time, and calculated the interval. "I'm going to flag your chart for an early repeat CBC," she said. "Your pressure's drifted a little overnight." "Is that bad?" "It's information. We treat information." He looked at her for a moment. "You're the first person today who didn't say you're doing great." "You're doing adequately," she said. "That's honest." Something in his expression loosened slightly. Sick people, she had found, often preferred accurate to reassuring. The reassurances made them feel managed. Accuracy made them feel seen. She flagged the chart, updated the note, and went to check on the pediatric patient in bed 11. The child, a 4-year-old named Cass, was asleep, finally, curled on her side with the particular boneless relaxation of small children who had fought sleep for hours and then collapsed completely. The mother, whose name was Joelle Martins, and who had indeed listed RN on her intake form, was sitting in the chair beside the bed with her arms crossed and her eyes on the monitor. "She's been sleeping for 40 minutes, Joelle said quietly, without looking away from the display. "That's good. Her temp is 99.2, down from 102.6, but her breathing rate was elevated for about 20 minutes before it normalized." Nora looked at the overnight notes. The respiratory rate notation was there, but flagged, then resolved. "I see that. Did anyone explain what they thought was causing it?" "They said viral, probably viral." Joelle finally looked at her. "I'm a nurse. I know what probably viral means. It means we don't have a definitive answer, but the pattern is consistent with a self-limiting infection and the current management is appropriate." "Yes, that's what it means." She paused. She had a febrile seizure 14 months ago, when she was 2.5. That's in her chart." "I told them 3 times." Nora pulled the chart on the tablet and looked. The febrile seizure history was in the intake form. It was not flagged in the overnight physician note. It was not referenced in the fever management protocol that had been followed. She did not say this to Joelle Martins. What she did was pull up the seizure threshold guidelines for pediatric patients with prior febrile seizure history and note that the fever management had been appropriate, but that the documentation gap created a care continuity risk. She added a note to the chart with the specific flag and sent a message to the covering physician queue for morning review. "I've updated her file," Nora said. "Dr. Lindquist will review it when she comes in at 7. If Cass's temp climbs again before then, I'll know about it." Joelle Martins looked at her for a long moment. She had the eyes of someone who had been in the professional position of caring for other people's children and now found herself on the other side of that equation, which was its own particular vulnerability. "Thank you," she said, simply, no performance in it. Nora nodded and left the room. Dr. Renata Lindquist arrived at 6:58 a.m., carrying a thermos and a tablet, and moving with the unhurried efficiency of someone who had organized the previous 12 hours to allow for exactly this pace. She was 54, lean, with reading glasses pushed up into steel gray hair, and the manner of a woman who had long since stopped performing patients and simply practiced it. She had been a trauma attending at Crestwood for 9 years. She had trained under a very different model than Elliot Graves, and it showed in small but consistent ways. She reviewed the overnight notes at the station, made 3 quiet notations, and then looked up at Nora. "You added the flag on the pediatric patient. The prior febrile seizure history wasn't referenced in the overnight physician note." "No," Lindquist agreed. She didn't appear defensive about it. "I'll talk to whoever covered, and I'll see the child first." She paused. "You also flagged Polk for an early CBC. His pressure dropped 4 points from the 3 a.m. reading, directional, not absolute." Lindquist looked at her for a moment with the specific attention of a physician assessing whether the person speaking knows what they're talking about. "Get the draw," she said. Nora had already ordered it. Lindquist made a sound that wasn't quite a smile. "How long have you been in?" "Since 6. "You transferred from where?" "Bayfield Community." Another pause. "That's a tough environment. Small resource base, high acuity for the facility size." "Yes. Good training ground." She went to see Cass Martins. The morning proceeded with the compressed variety of an emergency department that never truly lowers its activity level, only redistributes it. The GI bleed patient's CBC came back showing a drop in hemoglobin that confirmed the trend Nora had flagged. Not critical, but enough that Lindquist ordered a GI consult and initiated a transfusion protocol. Harrison Polk, told about this development, took it with the resigned acceptance of a man who had already spent 18 hours waiting for the other shoe to drop. "So the knee was more expensive than I thought," he said. "Your knee is fine," Nora said, hanging the first unit. "Your stomach lining has opinions about ibuprofen." "I should have taken the Tylenol." "Yes. My wife told me to take the Tylenol." "She was right." He was quiet for a moment. "She's usually right. I just hate admitting it." "You have 4 to 6 weeks to think about how to frame that conversation," she said. "Use the time." He laughed, a short, genuine sound that surprised both of them slightly. 2 bays down, a 40-year-old woman named Patricia Swan was being assessed for what the triage note described as severe headache and sensitivity to light, which could be 12 different things in an emergency department and which required a specific sequence of evaluation to narrow correctly. The resident assigned, Marisol Fuente, who had been on since 5 a.m., had ordered the right initial workup. The concern was that Patricia Swan was reporting the headache as a 10 out of 10, and when Nora went in to draw labs, the patient said something that the triage note had not captured. "It came on in like a second," Patricia said. "I was fine, and then I wasn't, like something snapped." Nora set down the blood draw kit. "Thunderclap onset," she said. "You felt normal, then in under a minute it was the worst headache you've ever had?" "Yes. Exactly like that. Is that relevant?" "I'll be right back." She found Marisol Fuente at the station. "Swan in bed 4. She's describing thunderclap onset, instantaneous maximum intensity. That wasn't in the triage documentation." Fuente's expression shifted. She knew what thunderclap onset meant. Every physician in emergency medicine knew what it meant and what it needed to rule out. "I'll get Lindquist." "I know." She was already walking back to the patient. The workup that followed was fast and correct. CT head without contrast first, then the specific follow-up imaging. The results came back 40 minutes later, showing what experienced emergency physicians always feared when they heard the words thunderclap headache, a subarachnoid hemorrhage, small but present, in a location that required immediate neurosurgery consultation. Patricia Swan, who had initially considered not coming in because she didn't want to be dramatic, was in the neurosurgery suite 3 hours later. Lindquist, reviewing the chart afterward, found the nursing note from the initial draw. She called Nora to the station. You got the thunderclap history in the room. She mentioned it when I was setting up the draw. It wasn't in triage. No, triage got severe sudden headache without the onset characterization. Lindquist looked at the note. The distinction is why she's in surgery instead of being sent home with Excedrin. Nora didn't say anything. That's a good catch, Lindquist said. It was a statement, not a performance. She said it the way she would have said it to a resident who had done something correctly, with acknowledgement and without fanfare. Thank you. Where did you train before Bayfield? A brief pause. Different places. Lindquist looked at her with the measured attention of someone filing a question rather than pressing it. All right. She went back to her work. Dr. Elliot Graves arrived at 12:47 p.m., 17 minutes late as always, and the atmospheric pressure of the department shifted in the small, specific way it did when someone with authority and defined opinions entered a space. He took the handoff from Lindquist at the station. Nora was nearby, charting. Renata, he said, scanning the summary. Interesting morning. Standard morning, Lindquist said. The subarachnoid in bed 4 was caught early. She's in surgery. Prognosis is reasonable. Who flagged it? A half-second pause. The nursing note identified the thunderclap characterization in the patient history. Graves looked up. His eyes found Nora without appearing to look for her. Which nurse? Vance. He made a sound that managed to be both neutral and somehow reductive, the vocal equivalent of filing something in a drawer that didn't require further review. Then he went back to the summary. Lindquist, whose expression remained entirely professional, handed over the remaining active cases and left at 1:05 p.m. At 1:08 p.m., Graves passed Nora in the medication corridor. Good identification on the headache presentation, he said, without slowing down. She waited a beat. Thank you. He was already past her. The acknowledgement had the quality of a receipt, confirming that a transaction had occurred without assigning it any particular value. She understood it for what it was. She had received similar acknowledgments from superior officers who needed to register competence without renegotiating hierarchy. The mechanics were identical, regardless of the institution. She went back to work. What followed over the next 3 days was the specific kind of institutional friction that doesn't announce itself. Graves did not confront Nora. He did not assign her to worse cases or reduce her responsibilities in any way that could be formally characterized. What he did was subtler and in some ways more precise. He spoke over her in patient assessments, not dramatically, just a fraction of a second before she finished a sentence, the way someone who has decided they are not really listening fills the silence preemptively. He addressed clinical questions to whatever physician or senior resident was present, rather than to the nursing staff, even when the nursing staff had direct care information that the physician didn't. He referenced the nursing team's report as a collective rather than attributing specific observations, which was a small linguistic choice with a consistent effect. Nora watched this without commenting on it. She understood the pattern because she had encountered its template before, not in hospitals, but in environments where the stakes of hierarchy were considerably less forgiving. The mechanism was the same: maintain the official record of fairness while systematically managing the narrative of who knows things. She adapted to it the way she adapted to most things, not by pushing against it directly, but by being precise in her documentation and consistent in her professional relationships with the people who were actually listening. Sandra Okafor, who had spent a career watching attending cycle through their various performances of leadership, was paying attention. Marisol Fuente, whose clinical instincts were good enough that she had noticed the asymmetry between Nora's catches and the credit those catches received, was paying attention. Even Dominic Kessler, who spent most of his time carefully not drawing attention to himself, had started positioning himself slightly closer to wherever Nora was working during complex cases. On the 4th day, something changed. It started with a patient named Roy Stetler, 58 years old, who came in via ambulance at 2:17 p.m., following a syncopal episode at his workplace. He had fainted at his desk, recovered consciousness within a minute, and then told the paramedics he felt fine, and this had probably happened because he hadn't eaten lunch. The paramedics, to their credit, had brought him in anyway. His initial vitals were unremarkable. His EKG showed a sinus rhythm. He was alert, oriented, and mildly embarrassed about the whole thing in the specific way that middle-aged men became embarrassed about anything that suggested physical vulnerability. He told Graves, who assessed him on arrival, that he felt completely normal and that he probably just needed a sandwich. Graves ordered standard syncope workup, EKG, labs, orthostatic vitals, echo if indicated, and moved to the next patient. Standard of care. Correct protocol. Nora was assigned to Stettler for the workup monitoring. She placed the telemetry leads, ran the first set of orthostatics, and sat with him for a few minutes while the lab draw processed. During that time, Roy Stettler mentioned, without particular emphasis, that he had been having episodes of feeling like his heart was stuttering for the past 3 weeks. Not painful, just an irregular sensation that came and went. He hadn't mentioned it to anyone because it went away on its own. How long did the stuttering episodes last? Nora asked. I don't know. Maybe 30 seconds, maybe less. Were they associated with anything? Exercise, eating, position change? Not really. Sometimes at rest. Once when I was driving. He paused. Is that bad? It's important information. I'm going to add it to your chart and flag it for the physician. She added a detailed nursing note, onset, duration, character, association with activity, the driving episode, and sent a direct message to the care queue flagging it as potentially relevant to the syncope etiology. Then she went to find Graves. He was in the middle of a conversation with Kessler about a different patient. She waited at a respectful distance. He finished his point to Kessler, looked at her. Stettler is reporting 3 weeks of intermittent palpitation episodes. Stuttering sensation, up to 30 seconds, occurring at rest as well as activity, including one episode while driving. I've noted it in the chart. Graves looked at her with the specific expression of a physician whose mental framework has already categorized a patient and is being asked to reconsider. Vasovagal syncope presentation, no prior cardiac history. He has no prior documented history, she said. He also hadn't reported the palpitation episodes to any physician. A beat. I'll review the chart, Graves said. He didn't move toward the chart with any urgency. Kessler, standing slightly behind Graves, caught Nora's eye with an expression that was carefully neutral. She went back to Stettler's bay. At 3:40 p.m., Stettler's telemetry alarmed. Not a catastrophic alarm, not ventricular fibrillation or complete heart block, but a 6-second run of a specific arrhythmia that the telemetry system flagged and that Nora saw on the monitor from 8 feet away before the alarm had fully processed. She was in the bay in under 4 seconds. The rhythm was back to sinus by the time she reached him. Stettler looked mildly confused. I felt that stuttering thing again, he said. I know. I saw it. She pulled the telemetry strip, documented the timestamp and duration, and was at the nurse's station flagging it as a priority message when Graves came through the corridor. Stettler just ran a 6-second burst of non-sustained ventricular tachycardia, she said. Converted spontaneously. He had his palpitation sensation during the event. Strip is printed. Graves took the strip from her and looked at it. She watched his expression change. Not dramatically. Elliot Graves was not a man who showed dramatic internal shifts. But there was a recalibration that happened behind his eyes, a physician's recognition of a sequence that has shifted its meaning. Get cardiology on the phone, he said. Already paged. He looked at her. She held his gaze for exactly long enough to register that she'd heard what he hadn't said, and then went back to the patient bay to stay with Stettler while the consult was arranged. Roy Stettler was admitted to the cardiac unit 2 hours later. The cardiology fellow who reviewed his case used the term appropriate early identification in the consult note and referenced the nursing documentation of the palpitation history as the flag that had changed the clinical trajectory. Graves did not amend his initial assessment note. He did not add an acknowledgement of the nursing flag in his subsequent documentation. He ordered the correct workup, managed the patient correctly, and did everything that could be formally documented as appropriate care. What he did not do was look at Nora differently. What he did not do was revise his operating assumption about who she was. And that night, in the break room, Nora overheard him tell Fuente that the Stettler case was a good example of why telemetry monitoring protocols existed, that the system had caught what it was designed to catch. Marisol Fuente, sitting across from him with a coffee cup and an expression carefully engineered to show nothing, said, Yes, the nursing observation on the palpitation history was a good flag. A pause. The telemetry caught the event, Graves said. That's the point. Fuente said nothing else. She was learning too. On the sixth day, Nora made a mistake. It was a small mistake, the kind that most clinicians made in the compacted judgment calls of a busy shift, and it resulted in no patient harm. She pulled the wrong concentration of a dilute solution from the medication cabinet. Not wrong drug, not wrong patient, but the 0.9% where the order specified 0.45%, caught it herself before it reached the line, corrected it, documented the near miss in the safety reporting system as protocol required, and moved on. She reported it to Sandra Okafor, as she was required to do. Sandra noted it, confirmed the self-correction, and closed the report appropriately. By 4 p.m. that afternoon, Graves had been told about it. Nora did not know who told him, though she had a reasonable hypothesis. What she knew was that at 4:23 p.m., Graves materialized beside her at the medication cart with the focused intention of a man who had been waiting for something and had decided this was it. "Medication error today," he said. "Near miss. Self-identified, self-corrected, reported per protocol. No patient exposure. Near miss is still an error in judgment." "Yes," she said. "It is." He waited, as if expecting her to explain or mitigate. She didn't. "In a high-acuity environment," he said, "the margin for that kind of lapse is very small." "I agree." Another pause. He had prepared for resistance, and she wasn't giving him any, which left him holding an argument with no purchase. "I'm going to note it in your performance file," he said. "That's your prerogative." She looked at him directly. "Is there anything else you need from me regarding the incident?" A beat. "No." He walked away. Sandra Okafor, who had been 2 supply bays over and not quite not listening, appeared at Nora's elbow, 20 seconds later. "He pulled your safety report personally," Sandra said quietly. "Within an hour of submission." Nora pulled the next medication from the cabinet and checked the label twice before confirming it. "I know," she said. "Most attendings don't even read the safety reports unless there's actual harm." "I know that too." Sandra looked at her for a moment. "You're not angry." "I'm something," Nora said, "but I don't have time for it right now." She went back to her patients. On the 8th day, the hospital had 3 simultaneous critical cases hit the ER between 7 and 9 p.m., which was the kind of convergence that tested whether a department structure held or fractured under load. A pediatric trauma from a fall, a respiratory failure in a COPD patient who had been borderline for 2 days, and a 31-year-old woman in septic shock whose initial presentation had looked like a bad flu. The sepsis case was Nora's. The patient, a young woman named Brianna Osei, brought in by her roommate who had been told repeatedly by Brianna that she didn't need to go to the hospital, had been in the waiting room for 40 minutes before triage moved her to a bed. Her initial vitals had been concerning but not alarming. Elevated heart rate, low-grade fever, low normal blood pressure. The triage nurse had categorized her correctly as urgent, not emergent. By the time Nora reached her, Brianna's blood pressure had dropped to 86 systolic, and her skin was mottled from the knees down. Nora called the sepsis alert, pushed 2 large-bore IVs herself in 90 seconds, had lactate and blood cultures ordered before the physician arrived, and started the fluid resuscitation while calling the attending simultaneously. The physician who arrived was not Graves. It was a hospitalist covering the overflow cases, a competent but junior physician named Dr. Thad Oren, who was on his 2nd year out of residency, and who saw the nursing setup and said, with genuine relief, "What do we have?" "Septic shock, probable source unknown, BP 8652 and dropping, lactate pending. 2 large-bore IVs, fluid running, cultures pulled. She needs vasopressors if the pressure doesn't respond to the next liter." Agreed. He was already at the bedside. Cultures from 2 sites? 2 peripheral, 1 before antibiotics. Broad spectrum ordered pending your confirmation. He confirmed it. They worked in the efficient parallel of 2 people who had agreed on a plan without negotiating every step. Brianna Osei's pressure began responding to fluids after the 2nd liter. Vasopressors were started as a bridge. She was transferred to the ICU 2 hours later in a condition that the intensivist described as serious, but stabilized with appropriate early intervention. Dr. Oren found Nora at the station afterward. "That setup probably gave us the 15 minutes we needed," he said. "She presented late. We needed every one of them." Yeah. He looked at the chart on the tablet. How'd you know before I got there? Vitals trend plus skin findings. The modeling was developing. He nodded slowly. Where did you train? The second time someone had asked her that this week. Different places, she said, as she had before. He looked like he wanted to ask more, but read something in her expression that suggested the question had a border he couldn't see. He thanked her again and left. What happened on the 9th day was something Nora had not planned for, which was unusual because she planned for almost everything. It started with a name. She was reviewing a chart at the station when a patient in Bay 6, a man named Nora Vance, admitted for chest pain under observation. Asked the orderly who brought his dinner for the name of the nurse with dark hair who had checked his IV earlier. The orderly came back to the station. Patient in 6 is asking about you, Voss. Nora went to the bay. Leonard Voss was 64 years old, with the weathered look of someone who had spent his career outdoors and the specific alertness of a man who believed in paying attention. You were in the service, he said, before she'd spoken. She stopped. How you move, he said. How you set up equipment. My son-in-law was a combat medic for 12 years. You move like he does. She held very still. I'm a civilian nurse, she said. Sure. He held her gaze with the patient certainty of someone who wasn't arguing, just stating. I just wanted to say I noticed, and that it matters. Whatever you did before you were here. He paused. My son-in-law got out 2 years ago. Took him a while to find his footing. He's a paramedic now. Good one. Another pause. He says the hardest part was people not seeing what he brought with him, only seeing where he was. Nora stood in the doorway of Bay 6 for a moment without moving. Is there anything you need, Mr. Voss? No, I'm all right. He settled back against his pillow. Just figured somebody should say it. She nodded once and left the bay. She stood in the corridor for 4 seconds doing nothing, which was unusual for her. Then she walked to the supply room, which was empty, and stood there for 30 additional seconds in the specific silence of a room with no one in it. She was not going to think about this right now. She went back to work. At 11:18 p.m. that same night, 3 military vehicles pulled into the Crestwood Regional Medical Center ambulance bay. Not police cruisers, not standard government vehicles. Military, the specific profile of vehicles that didn't belong in a hospital parking lot, arriving without announcement, moving with the coordinated efficiency of people who knew exactly where they were going and had already been briefed on the layout. Nora was at the station when Sandra Okafor looked up from the intake monitor with an expression Nora had not seen on her face before. We just got a priority notification from County Emergency Management, Sandra said slowly. Military medical transfer, classified casualties. They're coming here. How many? Sandra looked at the screen. 4 listed, possibly more. The department had 40 seconds to prepare before the bay doors opened. The first stretcher came through at speed, pushed by 2 people in tactical medical gear, and the patient on it, male, early 30s, with a tourniquet high on his right thigh, and field dressings that had been applied by someone who knew exactly what they were doing, was conscious but gray with blood loss. The second stretcher followed immediately, then the third. Dr. Graves appeared from the consultation room at a near run, still adjusting his badge. His voice went into the flat command register of an experienced trauma physician who had shifted into a different mode. What do we have? The tactical medic at the head of the first stretcher gave a rapid handoff. Right thigh penetrating injury, field tourniquet at 45 minutes, 2 peripheral IVs, blood products running, last systolic 94. The medic's delivery was clipped and precise in the way of someone trained to compress maximum information into minimum time. And then the fourth stretcher came through the bay doors. And everything stopped. Not literally. The stretcher kept moving, the personnel kept moving, the monitors kept alarming in the trauma bay. But there was a moment, a specific, identifiable moment, when the man on the fourth stretcher turned his head and looked at the emergency department around him with the unfocused assessment of someone fighting through blood loss and pain, and his eyes found Nora at the station 12 feet away. He was approximately her age, maybe a year or 2 older, and even gray with shock and blood loss. He had the look of someone who had been places that permanently altered how a person occupied space. He said one word, not loudly, not intended for the room, but the department was not as loud as it would become in the next 30 seconds, and the word traveled clearly. Calloway. Nora's hand stopped moving over the tablet she was holding. Every person within 10 feet who heard it looked at her, because Calloway was not her name. Calloway was not her name, but she moved toward the fourth stretcher anyway, and the way she moved, not hurrying, not hesitating, cutting a direct line through the controlled chaos of the bay entrance with the particular economy of someone who had done this before, in conditions with considerably less lighting and considerably more noise, told everyone watching something they didn't yet have language for. The man on the stretcher was named Garrett Hollis, though she would not learn that until later. What she knew in the first 4 seconds of reaching him was that the field dressing on his left shoulder was soaked through, that his respiratory rate was elevated above what pure pain explained, and that the tactical medic at his side was watching her face with an expression that was not the expression of someone handing off to a stranger. "Tension developing?" she asked the medic. "Maybe." Breath sounds were equal on scene, but that was 22 minutes ago. She put her hand on Hollis's chest without preamble. He turned his head and looked at her directly, and his eyes were more focused than they should have been for his presentation, the specific focused look of someone burning through pain on discipline alone. "Trachea midline," she said, more to herself than anyone. "Breath sounds." She reached for the stethoscope at her neck. Graves appeared at the edge of the stretcher. "I'll assess. Left side is diminished," she said. She had the stethoscope off before Graves finished the sentence and was already looking at the positioning of the shoulder wound relative to the chest wall. "The penetrating injury tracks toward the left upper lobe," she said. "The field dressing is on the shoulder, but the trajectory—" "I can see the anatomy," Graves said, with the sharp edge of a man who did not appreciate being narrated to in his own trauma bay. "Then you can see it's not a shoulder wound," she said, and she stepped back. It was the precise moves, not retreat, not deference, but the tactical withdrawal of someone who had made their point and was now allowing the person with the scalpel to act on it. Graves looked at the wound. He looked at the trajectory. He reached for the stethoscope himself and listened to the left side of Garrett Hollis's chest. 4 seconds. "Get me a chest tray," Graves said. His voice had changed, not softer, but stripped of the particular register he used when he was performing authority. This was the other version of Elliot Graves, the one that existed when the situation was serious enough that performance was a liability. 14-gauge needle, second intercostal, mid-clavicular line. Now. The tray was there in 40 seconds. Nora had already positioned herself on the opposite side of the stretcher, managing the IV lines, keeping Hollis's left arm clear, tracking his SAT on the portable monitor. Graves decompressed the left chest. The rush of air was audible and immediate. Hollis's oxygen saturation, which had been sitting at 91 and trending, began climbing within the first minute. Hollis exhaled, a long, controlled breath that was also something else, the particular sound of a body that has been working very hard against a problem that has just been partially solved. "Better," he said, to no one in particular. "Don't talk," Nora said. "Copy that." Graves was already calling for the chest tube setup. The trauma bay was fully engaged now. 2 other patients in adjacent bays, Fuente running the thigh tourniquet case, Kessler on the 3rd patient with the tactical medic providing history. The department had shifted into the specific operational mode of an institution under load, and the noise level was high and purposeful. In the middle of it, one of the military personnel, not the tactical medics, but a different figure who had come through the bay doors behind the stretchers and who had been standing near the entrance in a way that was neither frantic nor casual, moved toward Nora. It was approximately 45, in civilian clothes that did not fully conceal the bearing underneath them, and he had a credential holder at his belt that Nora clocked in her peripheral vision before she looked at his face. "You're Vance," he said. Not a question. "Yes." "CID," he said quietly. "Criminal Investigation Division. We need to talk about your background when this stabilizes." She held his gaze for exactly 1 second. "I'm working." "I know. I'll wait." He stepped back toward the wall and waited, which he apparently meant literally because he was still there 40 minutes later when the acute phase of all 4 cases had been managed and the department had lowered its operational pitch by several degrees. His name was Special Agent Damon Price, and he did not have the look of someone who made things easy. The 4 military patients were all stabilized by 1:15 a.m. 2 were moved to the ICU, Hollis and the thigh tourniquet case, whose name was Marcus Dern, and who had lost significant blood volume, but whose pressure had responded to resuscitation. The other two were admitted to surgical holding pending OR scheduling. In the space between the acute crisis and the administrative aftermath, the department existed in the particular liminal state of an ER that has just managed something difficult. Not celebrating, not resting, just existing at a lower register while the documentation caught up with the events. Graves found Nora at the supply station at 1:22 a.m. He stood beside her for a moment without speaking, which was itself unusual. "The trajectory call on Hollis," he finally said. "Yes. You saw that in the first 30 seconds. The field dressing placement didn't match the wound vector. It happens in field conditions. The medic addresses the most visible injury site, which isn't always the most significant one." Graves was quiet for a moment. He had the look of a man performing a private recalculation he hadn't expected to need. "Where did you learn to read field trauma?" he asked. She looked at him directly. "I told you, different places." He held her gaze, and for a moment something passed between them that was not warmth exactly, but was the specific tension of two people who have been operating in an incomplete understanding of each other, and who have simultaneously registered that the incompleteness is larger than previously estimated. He didn't push it. He walked away. Special Agent Price appeared at her elbow 30 seconds later with the reliability of a man who had been tracking the conversation from across the room. "Conference room available?" he asked. "Supply room is closer and empty," she said. They went to the supply room. "Yeah." Price closed the door and stood with his back to the shelving unit and his arms at his sides, which was either a habit or a deliberate choice to appear non-threatening, and Nora filed it as probably both. "Your personnel record at Bayfield Community goes back 4 years," he said. "Before that, there's a gap. I was between positions. 18 months is a long gap for a working nurse. I had personal circumstances." "Right." He pulled out a tablet and held it so she could see the screen without approaching. The document on it had a header she recognized and a case file number she also recognized, and her own photograph at the top from approximately 6 years ago, when her hair had been shorter and her expression had the specific quality of someone who has not yet learned to fully control what shows in their face under stress. "Your separation from active service was classified at the time of processing," he said. "The classification was lifted 8 months ago following a routine review." She looked at the photograph for 1 second, then at him. "Why are you here?" "Because Garrett Hollis recognized you and reported it to his chain of command during transport, and because Hollis is currently the subject of an active CID investigation into events that occurred during a mission in which you were also present." The supply room was very quiet. "I was separated from service," she said. "Whatever Hollis is involved in has nothing to do with me. That's what we're here to establish." He took the tablet back. "There's a Colonel Reyes who'd like to speak with you. Not tonight, but soon." "I'm a civilian nurse." "You are," Price agreed. "And you caught a tension pneumothorax in a classified military casualty that might have been missed for another 8 minutes in a busy trauma bay, which is the kind of thing that makes people ask questions about your background." He paused. "I'm not here to threaten you, Vance. I'm here because some of what's in that file concerns people who are still active, and we need to understand the full picture." She looked at him for a long moment. He was not lying, she assessed. He was also not telling her everything, which was standard, and she didn't fault him for it. "I'll need to speak with someone first," she said. "Legal counsel is available through—" "Not legal counsel, someone else." She held his gaze. "When does Colonel Reyes want to meet?" 48 hours. "I'll be available." He gave her a card, physical, not digital, which was its own information, and left the supply room in it alone for 30 seconds, then went back to the floor. The next 18 hours had the compressed quality of time that moves too fast when you need it to slow down, and too slow when you need it to move. She worked her shift. She was precise and present, and did not make additional mistakes. She spoke to no one about Price. What she did, on her lunch break, was make a phone call to a number she had not dialed in 14 months. The phone rang 4 times. Then a voice she recognized said, "Wasn't expecting to hear from you." "I know." "You all right?" "I need to know what happened with the Kessman Valley review," she said. "The file that was classified." A pause on the line. Not a surprised pause. More the pause of someone who has been waiting for a specific question and is now deciding how much of the answer to give. The review board completed 8 months ago, the voice said. They cleared the operation. All personnel. Were there findings? There were findings. Another pause. Some of which implicated individuals who weren't there. She processed this. Hollis. Silence. He's here, she said. At my hospital. The pause that followed was longer than the others. That's not a coincidence, the voice said. No, I know. Do you want help? She looked at the wall of the break room and thought about 14 months of deliberate distance from all of it, the specific work of building a civilian identity in a civilian institution and becoming genuinely just a nurse in an emergency department in Oregon. Not yet, she said, but stay reachable. She ended the call, ate the remaining half of her sandwich, and went back to work. Garrett Hollis was moved from the ICU to a step-down room on the 4th floor at 6 p.m. the following evening, which was faster than standard protocol, and suggested that someone with authority had made a call about his care trajectory. His chart noted him as stable, ambulatory with assistance, pain managed. Nora was not assigned to the 4th floor. She was assigned to the ER, where she remained for the entirety of her shift, and she did not go to the 4th floor, and she did not initiate any contact with Hollis or the military personnel who were rotating through the hospital in small numbers with credentials and the quiet efficiency of people running a parallel operation. But at 8:44 p.m., Garrett Hollis came to the ER. Not in crisis. He was ambulatory, moving carefully, in a hospital gown and grip socks with an IV pole he was using as a walking assist, accompanied by a young corpsman who looked like he hadn't been authorized for this particular excursion and knew it. Hollis stopped at the entrance to the ER floor and looked until he found her. She was at the nurse's station, charting. She saw him the moment he appeared. She finished the sentence she was entering in the chart, stood, and walked to the entrance rather than making him navigate the space. You shouldn't be walking this far, she said. I've walked farther with worse, he said. That's not the standard we're using. He looked at her with the direct, unrehearsed look of someone who has decided to say something they've been thinking about for longer than the current conversation. You saved my life twice, he said. Once 3 years ago and once last night. I wanted to say it to your face. She held his gaze. You need to go back upstairs. Calloway. That's not my name anymore. He stopped. He absorbed this with the specific quality of someone who understands the weight of a sentence like that. Not just the words, but the structure of choice underneath them, the deliberate distance between what someone was and what they've decided to be. Vance, he said. Yes. He was quiet for a moment. Price talked to you. Yes. He's not wrong that there's an investigation, but there are people in that investigation who would prefer the full record stayed complicated. He paused. The Kessman Valley Review. There are findings that exonerate you completely. There are also findings that some people would rather bury. I know about the review. Something shifted in his expression. Then you know it doesn't stay buried much longer. She looked at him for a long moment. The ER was functioning around them. Monitors, voices, the ambient operational noise of an emergency department at evening capacity. And she was simultaneously present in it and having a completely different conversation that existed in a layer most of the people around her couldn't access. Go back upstairs, Hollis, she said. Rest. Heal. Are you going to meet with Reyes? That's my business. He nodded slowly. He was not offended by this. He had the quality of a man who had learned that some people manage difficult information by controlling the radius of who they involved. For what it's worth, he said, Reyes is straight. She's not part of the problem. I'll decide that for myself. Yeah. He almost smiled. You always did. He turned to the corpsman. All right, let's go. She watched him make his way back toward the elevator, moving carefully on the IV pole, the corpsman hovering with the anxious energy of someone who had made a professional judgment call they were not certain would be vindicated. She went back to the station. Sandra Okafor was looking at her from across the desk with an expression that was not quite a question, but was not quite not one either. Old patient? Sandra asked. Something like that. So, at 10:30 p.m., Dr. Elliot Graves called Nora into the consultation room. This was not a routine thing. Graves summoned residents to consultation rooms. He did not generally summon nursing staff, which meant the conversation was either about the performance file entry from the medication near miss or about something new, and the specific quality of his expression when she entered, controlled in a way that required visible effort, suggested new. "Close the door," he said. She did. He was standing, which also told her something. He had a folder on the desk that he hadn't opened. "I received a call this afternoon from hospital administration," he said, "specifically from the chief medical officer's office, regarding your personnel record." She waited. "There's been a request from a military liaison attached to the patients we received last night to review your professional credentialing." He paused. "Not to revoke or challenge it, to verify that your current placement is consistent with your full qualifications." She said nothing. "They suggested," Graves continued, and now his voice had a quality she hadn't heard from him before, something between discomfort and a recalibration happening in real time, "that your clinical background may be significantly more extensive than your application reflected." "My application was accurate. I don't doubt that." He looked at the folder. "But there appears to be a period of your professional history that wasn't included, for reasons that were apparently not discretionary." She looked at him directly. "What do you need from me?" "I'd like to understand who I've been working with," he said, "and whether my assessments of your capabilities have been—" He stopped, started again. "Whether I've been operating with incomplete information." The room was quiet. Graves, she understood, was performing something that did not come naturally to him. Not an apology, not yet, but a genuine interrogation of his own framework, which was harder for some people than apology, and in some ways more significant. "You've been operating with the information I provided," she said. "My nursing license is valid. My clinical judgment has been sound. Anything beyond that is not relevant to patient care." "It's relevant," he said, "to how I've been managing you." She held his gaze. "Yes." He looked at the folder again. He did not open it. Whatever was in it was apparently not the kind of thing you absorbed easily at 10:30 p.m. after a long shift. "I owe you a different conversation," he said. "Not tonight, but I want you to know I'm aware of that." She assessed this, the specific texture of it, whether it was performance or something genuine underneath the performance. She couldn't be entirely certain, which was honest. Graves was complicated in the way of people who are genuinely capable and genuinely flawed, and have spent long enough succeeding that they haven't been forced to examine the intersection. "All right," she said. She left the consultation room. Hassan. The crisis came at 11:52 p.m. It did not announce itself as a crisis. The most dangerous ones never did. It arrived in the form of a cardiac monitor alarm from the 4th floor, specifically from the step-down room where Garrett Hollis had been placed, that came through to the ER because the 4th floor charge nurse had simultaneously called a rapid response and sent a direct message to the ER with a note that read, "Military patient, no staff present, requesting emergency physician immediately." Nora was at the station when the message came through. Graves had already been called and was moving. The rapid response team was deploying from the 2nd floor. She followed Graves to the elevator because the situation upstairs was developing, and she had information that nobody else on the rapid response team had. In the elevator, Graves looked at her. "You know something about this patient," he said. "It wasn't an accusation, it was an assessment." "He has a tension pneumothorax history and a recent chest decompression," she said. "His left lung re-expansion may be incomplete. If he's in distress, the differential isn't simple." "What else?" She met his eyes. "He's been under sustained physical stress for longer than his chart reflects. Field conditions for an undisclosed duration before transport. His reserves are lower than his presentation suggested." Graves absorbed this with the speed of a physician who has learned to process incomplete information under pressure. The elevator opened on the 4th floor. The scene in Hollis's room was controlled on the surface and not controlled underneath. The floor nurse, a woman named Andrea, who was very competent and had recognized immediately that something was wrong, had Hollis at 45 degrees and on high-flow oxygen, and the monitor showed a rhythm that was too fast and a saturation that was falling. But that wasn't the most pressing problem. The most pressing problem was that Marcus Dern, the patient from the thigh tourniquet case, who was in the adjacent room, had apparently gotten out of his bed and walked to Hollis's room, possibly because he heard the alarm, and was now standing in the doorway with a significant amount of his own deterioration beginning to show, his face gray in a way that wasn't just exertion, His right hand pressed against his abdomen with the instinctive pressure of someone whose body is telling them something urgent. "Dern," Nora said, moving toward him before Graves had fully entered the room. "When did the abdominal pain start?" Dern looked at her with the fixed clarity of someone fighting through several things at once. "Hour ago, maybe more." "On a scale?" "8, and climbing." She looked at his color, his posture, the specific way his weight was distributed. She looked at the timeline in her head. A patient with a significant thigh injury and significant blood loss who had been resuscitated and stabilized and who was now presenting with acute abdominal pain 18 hours post-admission. Her mind went to one place. "Graves," she said, loudly enough to carry across both rooms. "Dern needs an abdominal CT. Now. I think he's bleeding internally, and we've been treating the wrong injury." Graves, who was at Hollis's bedside, turned. "His thigh wound was the presenting injury," Graves said. "His thigh wound was the visible injury," she said. "He took a significant impact. If there was concurrent abdominal trauma that was masked by the thigh presentation, that's a significant assumption. He's been pressing his right upper quadrant for the last 40 seconds without realizing he's doing it," she said. "And his pressure is going to drop in the next 10 minutes if I'm right." Graves looked at Dern. He looked at the posture. He looked at the hand. He made the call. "Get me a portable ultrasound on Dern now and call surgery on call to the floor," he said to Andrea, "and get a second rapid response team up here." What followed was controlled intensity, the specific organized urgency of medical professionals who have agreed on a plan and are executing it in parallel. Graves managed Hollis's respiratory deterioration, which turned out to be a partial recollapse of the left lung requiring a return to more aggressive positioning and oxygen management rather than a repeat procedure, but which needed hands on it. Nora stayed with Dern, who was placed back in his bed with a portable ultrasound probe on his abdomen within 4 minutes. The image that came up on the portable screen was not ambiguous. Free fluid in the right upper quadrant, significant volume. The characteristic appearance of blood pooling in a space it should not be in. The surgery attending, a woman named Dr. Faye Holleran, who arrived in under 7 minutes with the focused energy of someone who had been sleeping and had fully woken up by the elevator, looked at the screen for 3 seconds. "He needs the OR, Holleran said. "Yes," Nora said. "How was this missed on admission?" The presentation was dominated by the thigh injury. The abdominal signs were likely subtle initially and developed over time. Holleran looked at her with the quick assessing gaze of a surgeon meeting someone new in a high-stakes context. "You flagged this?" "Yes." "Good flag." She was already moving, already talking to the OR coordinator on the phone. Marcus Dern was in the OR within 22 minutes. The surgical team found a grade 3 liver laceration that had been bleeding slowly and then, possibly triggered by his exertion in getting out of bed and walking to Hollis's room, had accelerated. He survived. At 2:10 a.m., the 4th floor was quieter. Hollis was stable. Dern was in surgery, and the reports coming up were manageable. The military personnel who had cycled through the hospital over the past 24 hours were doing the particular kind of waiting that operational people do. Contained, watchful, running their own calculations in parallel to everyone else's. Nora was at the 4th floor nurses' station finishing documentation when she became aware that she was no longer alone at the station. The woman who had come to stand beside her was not medical staff. She was approximately 50, in civilian clothes that were too deliberately ordinary, and she had the kind of controlled stillness that Nora associated with people who had learned to make themselves unremarkable in environments where being remarkable was dangerous. She had colonel's insignia on a credential at her belt that she made no particular effort to display or conceal. "Vance," the woman said. Nora looked up from the documentation. "I'm Reyes," the woman said. "I know we said 48 hours. I'm moving the conversation up." "Why?" Reyes looked at her with the particular directness of someone who has decided that the person in front of them doesn't need to be managed. "Because Hollis told me what you caught tonight," she said. "Both things. And because there are individuals who have been working to keep your service record incomplete, and those individuals are aware that you're here, and the window for a quiet conversation is getting shorter." Nora set down the pen she'd been holding. "How short?" she asked. Reyes looked at her steadily. "There's a man on his way to this hospital right now," Reyes said. He has credentials from the Inspector General's office, and he has a specific interest in ensuring that certain findings from the Kessman Valley Review never become part of the formal record. She paused. He was one of the people who authorized what happened in that valley, and he has known for 6 weeks where you were. The fourth-floor nursing station was very quiet. What does he want? Nora asked. Your silence, Reyes said. Formally obtained. And if I don't give it? Reyes held her gaze without flinching. Then we find out together what he's willing to do to get it, she said. And at that moment, the elevator at the end of the fourth-floor corridor opened, and the man who stepped out of it was not in military uniform, and he was not carrying anything visible, and he looked, walking toward the nurse's station with the calm of someone who has never in his professional life been told no in a way that mattered, like someone who had no idea what was standing between him and what he'd come to do. The man who stepped out of the elevator walked the way certain kinds of institutional power walked, unhurried, slightly ahead of whatever space he occupied, with the specific quality of someone who had spent decades in rooms where his presence changed what was possible. He was 61 or 62, silver-haired, in a dark suit that was too well fitted for a spontaneous middle-of-the-night hospital visit. His name, Nora would learn in the next 4 minutes, was Deputy Inspector General Warren Solt, and he had a credentials wallet in his left hand that he held slightly out from his body, the way people did when they expected it to open doors before they reached them. He saw Reyes first. Something shifted in his expression. Not surprise exactly, but the rapid recalculation of a man who had mapped the room before entering and found an element he hadn't accounted for. Colonel Reyes, he said. This is unexpected. I imagine it is, Reyes said. He looked at Nora. His assessment of her took approximately 2 seconds and carried the specific quality of a man sorting her into a category. Whatever category he chose, it wasn't the right one. Ms. Vance, he said. I'm Warren Solt, Deputy Inspector General, Defense Department Oversight. I'd like a few minutes of your time. It's past 2 in the morning, Nora said, and I'm on shift. This won't take long. He said it with the benign certainty of someone for whom inconvenience had always been something other people managed. There are some matters related to your previous service record that require clarification, specifically around your separation documentation and certain characterizations of events during a classified operation in the Kessman Valley region. Those files were classified, Nora said. The classification status changed 8 months ago. He smiled briefly, without warmth. Which I'm sure you're already aware of, given your conversation with Agent Price. So he'd been briefed on Price's visit. She filed this without showing it. I've already agreed to meet with Colonel Reyes, Nora said, in the next 48 hours. If the Inspector General's office wants to be part of that conversation, they can coordinate through her. Solt looked at Reyes with the patient expression of a man who had not come here to be redirected through channels. The IG's office operates independently of CID command structure, he said. Colonel Reyes' investigation and my office's review are separate matters. Then you can have separate conversations, Nora said, at a scheduled time, during which I'll have counsel present. A pause. Solt held his smile with the effort of someone maintaining a position under mild pressure. Of course, he said. I simply thought, given the circumstances, given that you've had contact with 2 of the personnel named in our review in the past 48 hours, a preliminary conversation might be beneficial, informal, off the record. Off the record, Reyes said, from Nora's left, with a tone that was entirely flat. At 2 in the morning, in a hospital where the subjects of your review are currently patients. Solt looked at her. The smile had developed a slight rigidity. Colonel, I'd like you to write down the time and your reason for being here, Reyes said. In my presence. Now. The fourth-floor corridor was quiet. The night shift nurse, Andrea, had withdrawn to the far end of the station with the professional discretion of someone who understood she was witnessing something she should neither interrupt nor ignore. 2 of the military support personnel who had been stationed near Hollis's room had materialized in the peripheral space of the corridor with the unhurried efficiency of people who had been signaled. Solt looked at the personnel. He looked at Reyes. He performed a rapid internal calculation that Nora could read fairly clearly. This had not gone the way the entry had been planned, and the window for the informal conversation he'd been counting on had closed before he'd reached the station. We'll schedule something, he said. The warmth was gone from his voice entirely. What remained was the voice underneath, flatter, more careful. Ms. Vance, I'd strongly recommend having that counsel present sooner rather than later. The review has a filing deadline, and representations made or not made by involved parties prior to that deadline affect the final characterization of events. It was a threat constructed entirely from reasonable-sounding procedural language. She had heard the form before. It meant, cooperate with our version of the record, or the record accommodates you less. I'll keep that in mind, she said. He left. The elevator doors closed behind him, and the fourth-floor corridor existed for a moment in the specific silence that follows the departure of someone who has compressed the air in a space by being in it. Reyes exhaled once, controlled. He got here faster than I expected. How did he know I was in the building? Someone told him. Reyes looked at her. Someone with access to the hospital's internal staff location system, which means someone here. Nora thought about this for exactly as long as it required. Then she thought about the performance file notation, the medication near-miss report pulled within an hour of submission, and the particular consistency with which her movements and catches had been tracked and managed by one specific person. She didn't say his name out loud. I need to make a phone call, she said. Use my phone, Reyes said. Not yours. The call lasted 6 minutes. The person on the other end was the same voice she had called from the break room 2 days earlier, and the conversation was compressed and specific in the way of people who had learned to communicate maximum content in minimum exposure. When she came back to the station, Reyes was reading something on her own secure device with the focused attention of someone receiving information in real time. Solt's review, Reyes said, without looking up. I've been trying to get the full scope for 3 weeks. His office has been running a parallel documentation process on Kessman Valley that characterizes the operation differently than CID's findings. Differently how? CID's investigation found that the extraction protocol was compromised by a command decision made above the operational level, a decision that put personnel in the valley longer than the mission parameters allowed. And that decision is traceable to 2 senior officers, one of whom is currently being considered for a promotion that would give him significant oversight authority. She looked up. Solt's version of the record attributes the complications to field-level decisions, specifically to the combat medical personnel who were managing the casualties. Nora held very still. He's rewriting it, she said. He's been rewriting it for 8 months, quietly, using the IG's review authority to create a parallel record that supersedes the CID findings in the promotion vetting process. Reyes set down the device. Your name appears in his version as the field medic who made independent calls that extended the exposure window, making you responsible for what happened. I was following orders, Nora said. Documented orders. I know. Reyes looked at her with the directness of someone who was not managing this information softly because she didn't have time to. The documentation exists, CID has it, but if Solt's version reaches the promotion board before CID's findings are formally filed, and his deadline is 72 hours, the promotion goes through, the CID investigation gets reclassified as inconclusive, and the official record of Kessman Valley is his version. And my separation documentation gets recharacterized as a performance-based separation rather than a voluntary one. The weight of this was specific and clear, not just to her history, her record, her separation, but to the nursing license built on that record, the application that had listed that separation, the 8 months at Bayfield, and the 9 days at Crestwood that depended on the licensing board never having a reason to look closely. He's been building toward this for 8 months, she said. Yes. And coming here tonight was an attempt to get you to sign a voluntary statement before you had counsel or understood the full scope. The statement would have been characterized as corroborating his version. Reyes paused. You handled that correctly, for what it's worth. It's worth something, Nora said. Not enough. No, Reyes agreed. We need the original orders documentation on file with CID before his deadline, and we need a statement from you on record under the CID investigation, not his review. How long do I have? 68 hours, roughly, but Solt is not going to wait passively. Reyes looked toward the elevator. He came here tonight because he thought you didn't know the scope. Now that he knows you do, he'll move faster. She went back to her shift. This was not avoidance. It was the most practical thing available to her at 2:30 a.m. The legal and investigative machinery that could help her was not available until morning. The documentation she needed was in federal systems she couldn't access from a hospital floor, and standing in a corridor running worst-case scenarios was operationally useless. She had learned this in environments considerably less forgiving than the fourth floor of Crestwood Regional. When you cannot act on a problem yet, you work on what you can work on, and you rest what you can rest. She went back to the ER. She finished her shift documentation. She managed 2 more patient cases, a chest pain presentation that resolved as musculoskeletal, and an elderly man with a urinary infection that had tipped into early sepsis, which she caught from the vital signs trend before the presenting complaint made it obvious. She did these things correctly and without drama. At 5:55 a.m., as the morning shift was arriving, Elliot Graves found her at the medication cart. He had the look of a man who had also not slept enough and who had been doing his own version of running calculations since the previous evening. "The military patient's on 4, he said. "Whatever is happening with their situation, and I don't have clearance to know what that is, I need to know if it creates risk for this hospital." She looked at him. "What kind of risk?" "Operational, legal. The kind that comes from having federal personnel circulating through the facility in the middle of the night, conducting what appear to be unauthorized informal interviews with staff members." She assessed how much to give him and decided on accuracy. "There's an IG review that may have procedural problems," she said. "Colonel Reyes is CID and she's managing it. The man who was here last night, Solt, was not here in an authorized capacity." Graves absorbed this. "He has IG credentials." "Credentials and authorization aren't always the same thing." She paused. "If he comes back, the hospital's legal counsel should be present. That's my recommendation." "Is this going to affect patient care?" "Not if I can help it." He held her gaze for a long moment. In the low light of the early morning corridor, with the overnight staff filing out and the day shift arriving, something in the architecture of how Elliot Graves was looking at her had changed from the first time she'd walked into his department 9 days ago. The framework he'd been using had developed cracks, not because he'd been told to change it, but because the evidence had accumulated past the point where the framework could hold it. "Is there something you need from this hospital?" he asked. It was a careful question, precisely delivered. "Not yet," she said, "but possibly." He nodded. "Then ask." She went home, slept 4 hours, and came back. What happened over the following 36 hours was not cinematic. It was documentation and phone calls, and the grinding procedural work of people trying to get accurate information into correct systems before a deadline imposed by someone who was betting they couldn't move fast enough. Reyes worked from a secure location off-site. The voice on Nora's contact number, whose name she still had not spoken aloud in the hospital, was a former JAG attorney named Brenna Dalton, who had left military legal practice 18 months ago and who was now in private practice in Portland, 40 minutes from Harlow, which was not a coincidence. Dalton drove to Crestwood at 9 a.m., reviewed the CID file summary that Reyes transmitted through proper channels, and spent 2 hours with Nora in a conference room that the hospital's legal counsel had cleared for the purpose. The order's documentation from Kesman Valley existed in 3 places. One was a CID evidence archive. One was a record Nora had maintained, on advice she'd received during her separation processing. In a secure location she accessed remotely during those 2 hours. The third was in the personnel file of one of the officers named in Solt's version of events, which meant it was also in Solt's possession, and which meant he knew it existed and had made a calculation about whether Nora still had her copy. He had calculated wrong. "This is the original operational order," Dalton said, reviewing the document on Nora's secure drive. "Signed, time-stamped, authorizing extended field presence specifically." "Yes." "And Solt's version attributes the extended presence to your independent decisions." "Yes." Dalton looked at the document for a long moment. She had the focused stillness of a lawyer who is seeing an argument clearly. "We file this with CID today," she said. "Not through channels, directly. I call the lead investigator and we transmit this afternoon. Solt's deadline is tomorrow morning." "I know, we'll beat it." She paused. "Nora, I want to be clear about what happens when we file. This doesn't stay quiet. The CID investigation becomes formal, the IG review gets flagged for procedural review, and Solt's parallel record gets examined, which means people start asking how a deputy IG managed to run an 8-month parallel documentation process on a classified operation without his own office catching it. He had cover, Nora said. The officer who benefits from the promotion, he has relationships in the IG's office. That makes it worse for both of them. Dalton looked at her. And it makes the filing more important, but it also means the response is going to be fast, and it may not be gentle. I've had ungentleness before. This is institutional ungentleness. That's different. Nora considered this. She considered the 9 days at Crestwood, the 8 months at Bayfield, the 14 months of deliberate civilian construction she had built around herself. She considered that all of it was contingent, had always been contingent, on the silence of people who had decided at some point that she was easier to manage when she was small. File it, she said. Bet. The filing happened at 2:47 p.m., and Solt knew about it by 3:30. Nora did not know how she knew he knew. She inferred it from the arrival at 4:15 p.m. of a hospital administrator she had never spoken to, a man named Gerald Fitch, who was director of compliance, and who appeared in the ER with the specific nervous energy of someone who had received a call he hadn't anticipated. He asked to speak to her privately. She asked Sandra Okafor to be present, which was her right, and which also produced a brief flash of discomfort in Fitch's expression. They used the same conference room. "I've received a call from a federal oversight office," Fitch said, expressing concerns about the employment documentation of a current staff member. He paused. "Specifically regarding the accuracy of qualifications listed in an application and whether certain prior conduct, in a previous professional context, was appropriately disclosed during the hiring process." Nora looked at him. "That's a characterization of my application. I'm not making an accusation. I'm relaying concerns that were expressed to me." "Who expressed them?" Fitch was quiet for a moment. "The call came from the Inspector General's office." Sandra Okafor, sitting to Nora's left, made no expression at all. She had been a charge nurse for 19 years, and she had the specific quality of someone who was cataloging everything being said for a purpose she had not yet announced. "My application was accurate," Nora said. "My nursing license is valid. My qualifications are real." She paused. "If the hospital has concerns about my documentation, I'll address them through HR with my attorney present. Is that what you're asking for?" Fitch shifted slightly. The concern raised was specifically about whether, in light of certain information about your prior service record, the manner of your military separation might affect your licensing status. "That's a determination for the licensing board," Nora said. "Not for you, and not for whoever called you from the IG's office." She looked at him steadily. "What I would note, Mr. Fitch, is that a federal official making a call to a private hospital employer about a specific employee's undisclosed disciplinary history, which is what you're describing, while that employee is simultaneously a witness in an active federal investigation, raises some significant procedural questions about that official's conduct." A pause. "I document this conversation," Sandra Okafor said from Nora's left, in a tone of such neutral practicality that it took Fitch a moment to process that it was directed at him, "including the time and the nature of the call you received. If there's any subsequent formal action regarding Ms. Vance's employment, you'll want that record." Fitch looked at Sandra. He looked at Nora. He appeared to be arriving at the understanding that the conversation he'd expected to have was not the conversation he was in. "Of course," he said. "I'll document appropriately." He left. Sandra waited until the door closed. "That was Solt pressuring the hospital to terminate you," she said. "Yes. Using your employment as leverage to get you to withdraw from whatever federal process you're involved in." "That's my read." Sandra was quiet for a moment. "Does Graves know?" "Not yet." "He should." She stood. "He's a difficult man, Vance, but he runs this department and he has relationships with hospital administration that I don't. If someone is about to try to have you fired, he needs to know what the actual situation is." She paused at the door. "Whatever the actual situation is." Nora looked at the conference room table for a moment. "The actual situation," she said, "is that I spent 3 years as a combat medical specialist attached to special operations units, including one classified mission where decisions made above my level put a team in a situation that went wrong, and a federal official has spent 8 months rewriting that history to protect a career that depends on those decisions being attributed to someone else, and I'm the someone else." Sandra stood in the doorway. "And the patients you've been catching things on for 9 days," she said slowly. The hemothorax, the subarachnoid, the sepsis, Hollis last night, Dern. Yes. That's not community hospital nursing. No. Sandra looked at her for a long moment with the expression of someone assembling a picture that had been developing for 9 days and has just come fully into focus. All right, she said. I'll find Graves. Graves came to the conference room 20 minutes later, and whatever Sandra had told him in the interim had done some of the work, because he came in without the performance, without the pacing deliberateness, without the calibrated slowness that was his professional register. He sat down across from Nora, and he looked at her with the specific directness of a man who has decided to stop managing his own response and simply be present for information. She told him what she'd told Sandra, and a few things she hadn't. She told him about Kesman Valley, not the classified operational details, but the shape of it. A mission that ran long, casualties that needed management, orders that were documented, and a senior officer whose career now depended on a version of events where the documented orders didn't exist. She told him about Solt's parallel record and the promotion timeline. She told him about the CID filing at 2:47 p.m. and what it was designed to do. She told him about Fitch's visit. Graves listened without interrupting, which cost him something. She could see that, because Elliot Graves processed information by talking and not interrupting was an act of discipline. But he managed it, and when she finished, he sat with it for a moment before speaking. The call Fitch received, he said. If Solt pressured a hospital to take employment action against a federal witness, that's potentially witness intimidation, Nora said. That's Dalton's assessment. She's filing a supplementary complaint with CID this afternoon. Does he know that? Not yet. Graves looked at the table. He had the quality of a man arriving at the understanding that the person sitting across from him had been managing something of this complexity while also working full shifts in his emergency department and catching things he and his team had not caught, and the arithmetic of that was producing a specific internal result. I owe you considerably more than I've given you, he said. You owe your patients accurate assessments, she said, which you've been providing. I dismissed you. You did. He met her gaze. The absence of deflection was genuine. She assessed that. I'm aware of what I did, he said, and I'm aware that saying it now, when you're useful to me in a way you weren't when you started, is a lesser version of the acknowledgement you deserved 9 days ago. He paused. I'd like to do better, if you'll let me. She held this for a moment. Graves was not a man who said things like this easily, and she gave the difficulty its weight. We'll see, she said. It was not dismissal. It was honest. He nodded. What do you need from this hospital? I need administration not to act on Solt's pressure. I need a documented record that his call to Fitch was unsolicited and that no employment action was considered. And I need that documentation transmitted to Dalton by end of day. I'll handle it personally. Thank you. She stood. He stood. They existed for a moment in the specific configuration of two people who have arrived at a different arrangement than the one they started with. The trajectory call on Hollis, he said, 2 nights ago. Yes. You've made calls like that before, in conditions where being wrong had a different kind of consequence. Yes. He looked at her with something that was not quite admiration, not quite regret, but contained elements of both. Then I'll try not to waste it, he said. At 7:45 p.m., Dalton called. CID confirmed receipt, she said. The lead investigator reviewed the order's documentation. They've issued a formal hold on the promotion vetting pending completion of the investigation. A pause. Solt's office was notified 40 minutes ago. How did they respond? They've requested an emergency procedural review of the CID filing authority, which is their right technically, but it's also going to take time they don't have before the promotion decision window closes. Another pause. His office also made a second call to Crestwood's administration at 6 p.m. I'm told it was referred directly to hospital counsel. Graves handled it. Apparently he was quite clear, Dalton said, and there was something in her tone that suggested the conversation had not gone the way Solt's office expected. Nora stood at the window of the break room and looked at the parking lot below, where the October evening was dark and wet and entirely unremarkable, and where nothing visible indicated that anything of significance was occurring. What's his next move? She asked. Honestly, he's running out of moves. Dalton's voice was measured, careful. The filing is in. The hold is in. His parallel record is now flagged. The Fitch call is documented as potential witness intimidation. He can appeal the procedural review, but that takes weeks and the promotion decision closes before the appeal resolves. A pause. There's one thing, though. Tell me. The officer whose promotion is on hold, his name is Brigadier General Vernon Haast. He has more resources than Solt, and he has considerably more to lose. Dalton paused. We've been treating this as a Solt problem, but Solt has been acting as an instrument. Haast is the source. Nora was very still. Is Haast aware of the filing? He was notified through official channels 40 minutes ago, Dalton said, at the same time as Solt. A pause. Nora. Haast has spent 8 months setting this up carefully through proper-looking channels. Now those channels have been disrupted in a way he didn't anticipate. Men like that don't absorb that information passively. No, she said, they don't. Reyes is aware. She's flagged it upward. That's good? Yes. But there's a window. Between now and when the formal holds create enough institutional weight to make direct action too costly for him, where he's going to be deciding what to do. Dalton paused. I want you to be somewhere safe tonight. Nora looked at the parking lot. I'm in a hospital, she said. That's not the same thing. She didn't argue it. She ended the call, stood in the break room for a moment, and then went back to the floor because there were patients, and she was still on shift, and the work was the work regardless of everything running parallel to it. At 9:20 p.m., Sandra Okafor appeared at the nurses' station with the expression of someone delivering information she would prefer not to deliver. There's someone in the lobby, Sandra said quietly. He's not a patient. He's been there for 20 minutes. He showed a military ID to the front desk and said he was here to speak with a staff member regarding a federal matter. She paused. He gave your name. Nora looked at her. Description? She asked. 60. Maybe older. Heavy build. Civilian clothes. Sandra paused. He has 2 people with him. They're staying near the entrance. Nora looked at the monitors at the station. She looked at the time. She looked at the layout of the floor she had memorized on her first morning and thought about every exit, every camera position, every staffed location between the lobby and the ER. Then she picked up the secure phone Reyes had given her 2 nights ago and called the only number programmed into it. Reyes answered on the second ring. Haast is in your lobby, Nora said, a pause that was exactly 1 second long and contained an entire recalibration. Don't go to the lobby, Reyes said. Stay on the floor. I'm calling this in now. How long? 12 minutes, maybe 10. The line stayed open. Nora set the phone on the station and looked at Sandra. Lock the ER entrance, she said, badge access only, and call security. What do I tell them? Tell them there's an unauthorized individual in the lobby who has identified a specific staff member by name and has not stated a medical reason for being here. She looked at her. That's accurate, and it's enough. Sandra moved. Nora looked toward the lobby entrance at the far end of the hospital corridor, beyond the sealed ER doors, where the cameras showed the lobby in 4 tiled rectangles on the security monitor at the station. In the bottom right tile, she could see the man Sandra had described, heavy-set, 60-something, with 2 individuals flanking him at a distance that looked casual and was not, standing near the information desk with his hands at his sides and his face turned toward the interior of the hospital. He was not moving toward the ER. He was waiting for something. And then one of the 2 individuals flanking him turned toward the lobby entrance, and the camera caught his profile for just long enough, and Nora recognized him. Not from Crestwood, not from any civilian context, from a road in a dark valley. 18 months ago, standing 40 meters from her position with a radio in his hand and an expression that told her, before anything else did, that the extraction was not coming. He was one of Haast's people. He had been there. And he was looking at the interior of the hospital with the specific focused patience of someone who had been told exactly which floor to go to and was waiting for a signal that it was time. The man in the lobby camera feed did not move toward the elevator. He stayed near the information desk, which told Nora something. He was maintaining a position, not advancing, which meant the signal he was waiting for had not come yet, which meant she had a window that was closing but not closed. She picked up the secure phone. One of the men with Haast was at Kessman Valley, she said, before Reyes could speak. He's not support personnel. He's operational. A half-second silence. You're certain? Yes. Then this isn't a conversation visit. Reyes's voice had dropped into the register of someone organizing information at speed. Stay away from any exit that feeds through the lobby. I'm 8 minutes out. I have 2 CID agents with me, and I've called the Federal Marshal's district office. Do not engage. Understood. She ended the call and looked at the security monitor. Haast had moved. Not toward the ER, toward the elevators. He was standing at the elevator bank now with his hands in his coat pockets and the posture of a man who had decided that patience had its limits and that the conversation he had come to have was going to happen tonight. The 4th floor. I was going to the 4th floor where Garrett Hollis was in a step-down room with a military corpsman outside his door and a documented statement filed with CID that was, as of 3 hours ago, a formal piece of an active federal investigation. Hollis was a witness. Hollis had seen what happened in Kesman Valley from 20 meters away, had been there when the orders came down, had been there when the extraction was delayed. And Haast knew that. She called the 4th floor nurses' station from the ER desk. Andrea picked up on the second ring. There is an unauthorized individual heading up on the elevator, Nora said, without preamble. Heavy build, 60s, civilian clothes, military ID. Do not allow him access to any patient rooms. Lock the controlled access door to the step-down wing and call security now. She paused. Tell the corpsman outside Hollis's room to lock the door and not open it for anyone without hospital staff present. What's happening? Andrea asked. I'll explain later. Move now. She heard Andrea shift immediately into action, which was what good floor nurses did when they received information with enough clarity and enough urgency that the appropriate response was motion, not questions. Nora looked at the elevator indicator. Haast was on his way up. She made a decision in the time it took to pick up her badge and move. The stairwell on the east side of the ER was not the fastest route to the 4th floor, but it was the route that didn't intersect with the elevator bank, and she took it at a pace that was not quite running, not because she was being cautious, but because running in a hospital at night produced attention, and she needed to arrive, not announce herself. She came through the 4th floor stairwell door 30 seconds before the elevator opened. Andrea had locked the step-down wing access door. The controlled corridor beyond it was sealed. But the elevator had opened and Haast was in the hallway now, with the single individual who had followed him up, the one Nora had recognized from the valley. And they were at the controlled access door when she came through the stairwell. Haast heard the door open. He turned. For a moment, the 4th floor hallway was simply 2 people looking at each other across a corridor, and the weight of what existed between them was not visible to anyone who might have passed by. But it was present in the way that certain kinds of truth are present, heavy, specific, and too large to fit into the available language. He was older than the photographs she'd seen. His face had the settled authority of someone who had spent a career being answered to, the specific quality of a man who had never truly had to consider the possibility that his version of events would not be the one that stood. Vance, he said. The tone was entirely controlled. General, she said, you've made a significant mistake today. You've made a significant mistake tonight, she said. Coming here. With him. She looked at the man beside him, who was watching her with the careful neutrality of someone running calculations. There are CID agents 6 minutes from this building, federal marshals behind them. Something moved in Haast's expression. Not fear, not yet, but the specific adjustment of a man re-estimating a situation. The CID filing will be contested, he said. The procedural grounds are substantial. Brenna Dalton anticipated that, she said. The contestation process requires a formal hearing, which requires all documentation to be held in current state pending resolution, which means the promotion vetting cannot proceed until the hearing is complete, which takes approximately 4 months. She paused. The promotion window closes in 11 days. A silence. The IG review has been flagged for an internal procedural audit by the IG's own oversight board, she said. That was filed at 5 p.m. today. Dalton found 2 other cases in which your review methodology was applied to reclassify operational findings in ways that benefited officers under review. You've done this before, not as carefully as this time, but enough to establish a pattern. The hallway was quiet. Behind the controlled access door, the step-down wing was sealed and silent. The man who had been in the valley, whose name she still did not say aloud, had stopped with his weight distributed in a way that was not casual. She noted it. She noted the distance between them, the layout of the corridor, the position of the stairwell door behind her. She had been in worse geometry than this. "This ends badly for you," Haast said. His voice had dropped. The public register was gone. "No," she said. "It ends badly for you. The only question is how publicly." And then the stairwell door opened behind her, and Reyes came through it with two people who wore the specific clothing and carried the specific credential holders of federal investigators who were not asking permission for anything. Well, what followed was not dramatic in the way of television. There was no shouting. There was no physical confrontation. Haast was a man who had spent 40 years understanding which rooms he could control and which ones had shifted past his control, and the fourth-floor hallway of Crestwood Regional Medical Center at 9:47 p.m. on a Wednesday was a room that had shifted. He submitted to the identification process with the rigid composure of someone storing everything for the legal response he was already constructing. The man from the valley, whose name was Carl Moss, which Reyes used when she addressed him, submitted with the particular stillness of someone who had assessed the situation and concluded that the least costly option was compliance. Reyes handled it with the economy of someone who had done this before and who had no interest in performing it for an audience. The CID agents were efficient and not unkind and moved Haast and Moss toward the elevator with the specific professional neutrality of people executing a process, not making a point. Before the elevator closed, Haast looked at Nora once more. She looked back. She did not feel what she had expected to feel, which was the thing that complicated moments like this always produced. Something between satisfaction and the hollow specific exhaustion of having spent enormous energy on something that should never have been necessary. What she felt instead was simpler and harder to name, the sensation of a weight that had been distributed across her skeleton for 18 months, beginning not to disappear, but to shift into something she could carry differently. The elevator closed. Reyes turned to her. "Moss is going to cooperate," Reyes said. "He knows the exposure. His statement combined with yours and Hollis's is going to be very thorough." "When?" "Tonight, if he agrees to the terms. His attorney is going to tell him the same thing mine would, that cooperation now is substantially better than the alternative later." Andrea was at the step-down wing door, having heard enough through the locked door to understand that whatever had been happening in the hallway was over. She looked at Nora with the wide-eyed expression of someone who had spent 30 minutes on the other side of a locked door not knowing what was on this side of it. "Is everyone all right?" she asked. "Yes," Nora said. "Hollis can unlock the room." She stayed on the fourth floor long enough to confirm that Hollis was physically fine. He had been awake, had heard enough, and had the expression of a man who had been in enough situations to recognize when one had resolved. And then she went back downstairs because there were patients, and the work did not stop because her life had just tilted on its axis. The days that followed were the procedural aftermath of something that had been building for 18 months and required considerably more than a single night to fully resolve. Moss gave his statement before midnight. It was detailed and specific and corroborated the order's documentation in ways that closed the remaining gaps in the CID case. Haast's attorney filed 3 separate challenges in the first 24 hours, all of which the CID lead investigator described to Reyes as anticipated and manageable. The promotion vetting was formally suspended on Thursday morning. The IG's Internal Oversight Board opened a formal review of SOLT's parallel documentation process on Friday. None of this happened cleanly or without friction. Institutional machinery of this size and weight moved with the grinding inefficiency of systems designed to resist change, even correct change, because the resistance was built in. There were days when Dalton called with developments that were encouraging and days when she called with procedural setbacks that required regrouping. There were filings and counterfilings, and one particularly frustrating week when a jurisdictional question about which office had primary authority over the evidentiary record threatened to delay everything by 30 days before Reyes found the correct internal escalation channel and resolved it. Nora worked through all of it. She went to her shifts. She caught things. She prevented a medication interaction in a post-surgical patient that the prescribing physician had not flagged. She correctly identified an atypical appendicitis presentation in a woman whose primary complaint had been back pain and whose appendix was in an anatomically unusual position. She held Roy Stetler's hand when he came back to the ER for a follow-up cardiology device check, and was scared in the way that patients who had almost died and knew it sometimes became scared during routine appointments. And she sat with him for 7 minutes that she technically did not have, and told him that scared was appropriate, and that appropriate was different from dangerous. She made 2 more mistakes during that period. 1 minor medication charting error she caught herself. 1 assessment call on a patient's pain level that she subsequently revised when new information came in. She documented both and reported both, the same way she had reported the first one, and neither produced a visit from Elliot Graves. What Graves produced instead was different. 3 weeks after the night in the lobby, Graves asked her to stay after a shift. It was late afternoon, the department at middle volume, the October gray having deepened into November with the particular commitment of Pacific Northwest autumn. She waited at the nurse's station while he finished a consult, and when he came to stand across the desk from her, he had the specific quality of a person who has organized what they want to say carefully and is still uncertain whether it will land correctly. "I've spoken to the CMO," he said, "and I've spoken to nursing administration." She waited. "There's a position that doesn't currently exist at Crestwood," he said. "A clinical coordination role, specifically for high-acuity triage and multi-system trauma assessment. Not administrative, hands-on." He paused. "It would require creating the position, which requires board approval, which I've been told is likely given the formal recommendation I've submitted." She looked at him. "You submitted a recommendation?" "Last week." He held her gaze. "I should have done it day 2, maybe day 1. Another pause. "I'm aware that I am not the person whose opinion of your qualifications matters most. But in the context of this hospital, in the context of what I can actually do, I wanted to do something concrete." She was quiet for a moment. "What does the position entail?" she asked. He told her. The scope, the patient population, the degree of clinical independence, the capacity to flag cases across departments rather than only within the ER. It was, she assessed, a role that had been designed by someone who had spent 3 weeks thinking about what she actually did and how to build institutional space for it. "It also comes with a conversation," he said, "a formal one, about my conduct over the first 9 days you were here. That conversation is available to you through HR whenever you want it." "I don't need HR for that conversation," she said. "No," he agreed, "but the offer stands." She looked at the nurse's station, at the monitors and the charts, and the 4 patients currently visible through the bay windows at varying stages of various crises. "I'll think about the position," she said. "That's all I'm asking." She went home. She made dinner, actual dinner, not a sandwich over a medication cart, and sat at the table in the apartment she had stopped renting by the week 2 weeks ago and eaten it in the specific quiet of a person who has more room in their own life than they had recently been occupying. She thought about the position. She thought about what it meant to build something in a place rather than simply existing in it. She thought about the 14 months she had spent making herself small in ways that had felt like protection and had sometimes also felt like a different kind of loss. She called Dalton. "The Kesman Valley Review," she said. "Timeline. CID expects to complete the formal findings within 60 days. Haas challenges are slowing the process but not reversing it. Moss's testimony is strong." Dalton paused. "Your separation documentation is already being flagged for review by the board that processed it. The recharacterization Solt's version would have produced, that's not going to happen. The record stands as voluntary separation with full honors." And Haast. "The promotion is dead. The IG oversight review of Solt is generating additional findings that are going to make the disciplinary outcome considerably broader than just the Kesman Valley case." A pause. "Nora, I want to be honest with you. The formal institutional consequences will take time. These processes always take longer than they should, but the trajectory is clear." "I know." "Are you all right?" She looked at the window. Outside, the November rain was consistent and indifferent and entirely familiar. "I'm working on it," she said. "That's honest." "That's enough," Dalton said. The formal findings from the CID investigation were released 53 days later, on a Tuesday in January, when the Oregon coast was in the middle of a storm system that had shut down 2 highways and was keeping the ER at Crestwood Regional at steady high volume. Nora learned about the release from Reyes, who called at 7:15 a.m. before Nora's shift started. "It's clean," Reyes said. The findings reflect the actual sequence of events. Your role is characterized accurately. Field medical specialist acting under documented orders in conditions created by command-level decisions above your authority. A pause. Haast is named as the officer whose decisions extended the operational exposure. The findings have been transmitted to the promotion board, the IG oversight process, and the licensing review board that was evaluating your professional record. SOLT? Referred for formal disciplinary proceedings. The pattern across cases was significant enough that the IG's own office is treating it as a systemic issue, not an individual one. Reyes paused. There will be a public record. Not everything. The operational details stay classified. But the findings related to the documentation manipulation are going to be accessible. Nora sat in her car in the Crestwood parking lot with the rain hammering the windshield and the 7:25 start time 4 minutes away. Reyes, she said. Yes. Thank you for moving when you did. A pause on the line that had the quality of something genuine in it. You'd been carrying this alone for 18 months, Reyes said. You shouldn't have had to. No, Nora said, but I did, and I'm still here. She ended the call, sat for 10 more seconds, and went inside. The moment that Nora would remember most clearly from that morning was not the phone call, and was not the findings document, and was not anything procedural or institutional. It was smaller, and happened in the middle of a shift that was already at capacity. She was in Bay 3 with a 17-year-old named Tomas, who had come in with his mother after a sports injury that had turned out to be a fracture, and who was in the specific state of a young person who was trying very hard not to show how scared he was and not fully succeeding. His mother sat in the corner chair with her coat still on because she'd come straight from work and hadn't processed yet that she could take it off. Nora checked the splinting and explained the follow-up protocol and was adjusting the pillow positioning when Tomas said, out of nowhere, "Are you the nurse who figured out the thing with the liver? My cousin was here last month, Marcus Dern." She looked at him. "Yes," she said. He looked at her for a moment with the frank assessment of a teenager who hasn't yet learned to soften his curiosity. "He said you figured it out when the doctors didn't. The team managed it correctly once it was identified." "He said you identified it." She finished adjusting the pillow. "How is he doing?" "Good. He walks okay. He's still mad he has to sit out of..." He stopped. "You're not going to say you saved his life, are you?" "No." "He said you wouldn't." He looked at her with the specific wonder of someone encountering a type of person they haven't encountered before. "He said you were the quietest person he'd ever met, and you scared the hell out of everyone in the room." His mother, from the corner, made a small sound that was not quite a laugh. Nora checked the time on the monitor. She had 3 other patients. "Take the anti-inflammatory with food," she told Tomas. "Keep it elevated tonight. Follow up with orthopedics in 5 days, not 7. It's a clean fracture, but the growth plate position warrants sooner." She looked at his mother. "You can take your coat off." His mother looked down at herself. She had genuinely forgotten. "Oh," she said, and started taking it off with the slightly dazed quality of someone re-entering a body they've been holding at a distance. Nora went to her next patient. She accepted the position in February. The conversation with Graves was brief and professional and contained. At the end of it, one exchange that neither of them elaborated on but that both of them understood. "There's one thing I want to say," Graves said, "outside the professional context. All right? What I said to Fuente and Kessler the first week, about community hospital nursing and clinical authority." He held her gaze without flinching from it. "That was wrong. Not just about you. It was wrong as a general principle, and I've been practicing it for a long time." A pause. "I don't know how many people that's cost over the years. I can't fix the years. I can fix how I operate going forward." She looked at him. "I know you can," she said. "I've watched you for 4 months. You're capable of it." It was not absolution. She did not owe him absolution. What it was accurate, and she had found, in the course of a life spent in places where accuracy was the only reliable currency, that accurate was usually more useful than kind, and sometimes, when the timing was right, they were the same thing. He nodded once. She signed the paperwork. Sandra Okafor found her in the break room on the day the position was formally announced to the department. She handed Nora a coffee that was actually hot, which in the ER was the closest thing to ceremony that the environment supported. Clinical Coordination Specialist, Sandra said. That's a title. It's a lot of words. You earned every one of them. Sandra looked at her with the specific directness of a woman who had spent 19 years watching people come through this department and had developed excellent judgment about which of them were worth watching. What are you going to do with it? Nora thought about this honestly. The triage backlog on high acuity presentations, she said. There's a pattern in the data where complex multi-system patients spend too long in the wrong priority tier because the initial presentation doesn't surface the complicating factor. She paused. I want to build a flag protocol, systematic, something that outlasts any individual nurse's pattern recognition. Sandra looked at her for a moment. You want to make yourself replaceable. I want to make the system better, Nora said. Those aren't the same thing. Sandra drank her coffee. No, she said. I suppose they're not. Garrett Hollis was discharged from Crestwood Regional on a Friday afternoon in late October, 6 weeks after he'd arrived on a stretcher through the ambulance bay. He walked out under his own power, which he had worked toward with the particular stubbornness of a man who had decided that being carried out was not acceptable. The corpsman who had been his unauthorized escort to the 4th floor was not there this time. Hollis had eventually clarified that the kid had acted without authorization and had received the appropriate conversation from his chain of command, though Hollis had also made clear that he personally found the whole thing admirable, which was the kind of contradiction that made Hollis human. He found Nora at the nurse's station before he left. She looked up. You look considerably better, she said. Barr was on the floor, he said. But he was standing straight, and the color was back in his face, and the specific gray of blood loss and shock had been replaced by the weathered, ordinary color of someone who had been through something and was intact on the other side of it. Reyes told me about the findings, he said. Yes. The record's straight now. Getting there. He looked at her with the direct and uncomplicated sincerity of someone who has decided that the particular social negotiation around expressing gratitude is less important than actually expressing it. You kept me alive twice, he said, in completely different ways. I'm not going to pretend I know how to adequately account for that. Don't try to account for it, she said. Just take care of yourself. That's the return. He considered this. That's a very practical view of gratitude, he said. I'm a practical person. Yeah, he almost smiled. I remember. He left. She watched him walk through the ER doors into the parking lot and then turned back to the chart she'd been updating because there was always a chart and there was always a next patient and the work was the work. What? There is a specific thing that happens to people who have been dismissed for long enough. A compression that occurs at the level below conscious awareness. A gradual recalibration of how much space they are permitted to take up in any given room, how loudly they are allowed to register their own presence. It is not always dramatic. It often looks, from the outside, like professionalism, like restraint, like someone who simply prefers to let their work speak. And sometimes that is what it is. But sometimes, more often than the people doing the dismissing ever consider, it is something else. It is the accumulated weight of being told, in 1,000 small and large ways, that what you know, what you have earned, what you are carrying, does not carry sufficient credibility in the room you are standing in. Nora Vance had been carrying that weight for 9 days in an emergency department that had decided what she was before she had the chance to show them. She had been carrying a different, heavier version of it for 18 months before that. And before that, she had carried the professional version of it through 3 years in environments where dismissal was not an institutional policy, but a tactical decision made by people whose authority was measured in lives. What she knew, that most of the people who dismissed her had not yet learned, was that the weight did not have to be put down. It could be carried differently. It could be transformed over time and with sufficient intention into something that functioned not as a burden, but as a specific kind of knowledge. The knowledge of what it costs to be unseen, which was the only knowledge that made it possible to truly see others. She thought about this on a Tuesday morning in March when she ran her first formal triage protocol review with the ER nursing staff, a group of 12 people in a conference room with bad coffee and varying degrees of skepticism about whether a new protocol was necessary or whether it was simply an administrative response to a series of high-profile catches by a single nurse. She stood at the front of the room and looked at them. This protocol isn't about improving on what any of you are already doing, she said. It's about building a system that catches what the human eye misses when it's moving too fast and managing too much. Every flag in here came from an actual missed presentation from the last 18 months. Every case was real. Some of them resolved fine anyway. Some of them didn't. She paused. The point is not who catches it, she said. The point is that it gets caught. The skepticism in the room did not disappear. It shifted from the defensive skepticism of people who expect to be criticized into the active skepticism of people who are actually engaging with something. That was enough. It was usually enough, she had found. You did not need people to agree with you on day one. You needed them in the room, and you needed the work to be real, and you needed to show them that you were not asking them to trust you. You were asking them to trust the process, which was built on evidence and had their own experience embedded in it. Marisol Fuente, who had been in the room for that conversation and who had never said anything about the first week and who didn't need to, caught Nora's eye at the end of the session. Good protocol, she said simply. It'll need revision, Nora said. Bring me the cases where it doesn't work. Fuente nodded. I will. In the parking lot that evening, with the March rain doing what Oregon rain did in March, which was exist comprehensively and without apology, Nora sat in her car for a few minutes before driving home. She thought about a road in the dark. She thought about 9 minutes with no margin. She thought about a 17-year-old named Tomas, who was probably walking on his healed fracture right now, and his mother who had finally taken her coat off. She thought about Harrison Polk and the stomach lining that had opinions about ibuprofen and the wife who had been right about the Tylenol. She thought about Patricia Swan, who was alive because of a detail mentioned during a blood draw. She thought about Marcus Dern, who had walked out of this hospital under his own power to his cousin, who played sports and was going to be fine. She thought about all the things that get dismissed before they're understood. All the knowledge that gets sorted into the wrong category by people moving too fast on incomplete information. All the expertise that goes unrecognized, not because it isn't present, but because the person carrying it doesn't fit the expected shape of someone who carries such things. She thought about what it had cost her to stay quiet long enough for the work to speak. And she thought about the fact that silence, when it is chosen rather than imposed, is not the same thing as smallness. She had chosen it, until she hadn't needed to anymore. The rain was not letting up. She started the car. There was a shift tomorrow and a protocol revision session. Thursday, and a follow-up conversation with Dalton about the final IG disciplinary outcomes, which were expected to include Solt's formal removal and Haas's referral for proceedings that would, quietly and without ceremony, end the career of a man who had spent 8 months betting that she would stay small enough to be managed. He had been wrong about what she was. Most people were at first. She had stopped finding this surprising. She had started, slowly and imperfectly, and without any dramatic announcement, finding it useful, not as armor, not as strategy, but as a reminder that the distance between what people expect of you and what you actually are is not a problem to be solved. It is simply space. And what you do in that space, in the quiet before the room catches up to you, is the only thing that was ever fully yours. She drove home in the rain. She made dinner. She was back at 6 a.m. She was always back. And that, she had decided, was the only kind of recognition that had ever truly mattered. Not the formal findings, or the position title, or the apology from a man who had needed 3 months to find the words, but the simple, repeated, unspectacular act of returning. Of choosing, every day, to be where the work was, doing the thing that she knew how to do, for people who needed it done. Nobody gets to decide who you are by underestimating you. That is their error. What you do with the space it creates, that is yours.